So without wasting much time, let me tell you a breaking news. You have two mentees who are under a mentorship of one mentor. And it was initially thought that both of them will present to actually will collate the marks and they go to the finals. But because of the some logistics, then there's an APAO conference. Even our organizers had trouble finding the time and venue and the slots. So we have been forced to take a call that only one will present from the team, not both of you. So we'll not take any lots or anything. You can decide with your mentors and between yourself that who is the one who will represent the team, not both of you. So that marks will be considered, and in the finals both of you will present. Okay, that will be a different topic. So I'll just take an attendance. Please raise your hands. Any one of them is there, it's fine. Dr. Moria's Master Blasters, not the mentor, mentees. Okay. The Oaks Trio, yeah. You can maybe even shout out also. Wizards of JNEC? Yes, no? Okay. See, I don't really mind if your name is here and you're not here. If you are here and the name is not here, there's a problem. That's why. SDN Pandits, A-Train, DDU Dynamos, Akilo Catalyst. What names there? Okay. The Iconic Trio, whatever. Fine. IQ TOTs, Indocyanins, okay. Visionaries, Eye Openers, Corneal Crusaders, okay. Okay, don't say yes or no. If your name is not there only, then you shout out. That's better. Udaipur Royals, Upside Down, New Horizon, I Teach, Cortical Chasers, Symbiotes, Vanquishers, Ame Racers, Team M&J, RIO Achievers, the Optimenters, Kavita's Teaching Angels, Iconic Crusaders, CFS Retina, Trichromats, Kaveri, Marvel, Sight Seekers, Southern Stallions, the Ocular Luminaries, Dr. Atiya P, Team UCMS, Sight Seekers, SVMC Tirupati, NN Edu Trainers, Neuro Nexus, Sight Savers, Sight Servants, whatever. ESI, PGS, MSR, New Delhi, Lens Legends, Retiglow, Ofta Oracles, Rods and Cones, Spectacular, Team PGIMS, the Iconics, Icon Mentors, Incomplete. What is Incomplete? I don't know. Synergist, Classroom Catalyst, Glowing Gadag, Team Iconica, Jedis, I Avengers, Teaching Titans, Guru Shishya, SCB Odisha, Progressive Pioneers, Mavericks, Visionaries, RIO Rockstars, IQ Experts, the Visionaries, MGM IQ, iConquer, Iconic, the Visionaries, Vitriovitis, AFMC, Gen Z Teachers, Pupil Professors, Jupiter Gurus, Team VK, IQ Crew, Maverick, the Pink City Optic Nerds. Anybody whose name doesn't figure out in this list? Okay, fine. So the rules are, write your name everything. Okay, I'll quickly tell the rules. We have the judges who are ready. The time allotted is, so the time allotted is strictly 3.5 minutes only. That is 210 seconds. Why it is strict? Because you are going to lose marks if you overcross even by 5 seconds. So make sure that you finish before 3.5 minutes. The judges will judge you only on 10 marks. 10 is the maximum marks that you can get. 5 marks for the content. The way, how relevant is your coverage of the topic to the topic allotted. How you actually make your slides, what is the content, slide quality, the fonts used, the animations, images, videos, all those things. How is your actually presentation? Both, that is important. Another 4 marks for your speaking skills, the confidence, the stage presence, the body language, the histrionics, voice intonations, the way in which you actually present and teach, and the use of props, everything comes under your the teaching abilities. And only 1 mark is for the finishing within time, which is the lowest hanging fruit. You can always get it before finish before 3.5 minutes. Okay, so we will. No questions. No questions asked. There will be no questions from the judges. So be happy about it. Judges, you also be happy about it. You don't have to start thinking about what question to ask. But only thing is, if they cross 5 seconds beyond 210 seconds, you will cut 1 mark. And the maximum marks for the content is 5. Maximum for the teaching ability is 4. 1 for, so that is the maximum 10. या सबको उनको बोल दो सबको ऐड करने के लिए राइट इन एवरीबॉडीज पेपर मैं माइल लिख दूंगा उधर तक So at the same time we want to finish all of you today itself because there is a Sukhvinder's program in the gala dinner. We don't want you to be singing the songs here till late night, so we have a plan of having an alternate thing. So we have the other trade halls which are going to get emptied in another 1 hour. So we're going to shift some of them to that, the last contenders, so that we all can finish together and go to the gala dinner. Right? Okay. So I will read out the first 5 teams. So be ready in that order, and you have to load your presentations and be ready. So we'll start with the first is Moria's Master Blasters. The second team will be presenting is Vokes Trio. Are you there? Vokes Trio? Yeah. Wizards of GNEC is there? Okay, be ready. SDN Pandits? Yes. Come to the front. A Train? No A Train. Okay, you are there. So this is the order. And judges, please note the names of the teams and... So can we have the presenting mentee from the Moria's Master Blasters? Nahi aa rahi? On the way. So Vokes Trio. Please. दोनों पोडियम यूज करेंगे ना? वॉलंटियर है तुम्हारा कोई स्पीच वगैरह? नहीं, उनको दोनों साइड में रेडी कर देंगे टॉपिक को, सो दैट अगले पे भी लिख लो। दूसरा टॉपिक बना के हम सूट ढूंढ के करेंगे बस। दिस विल टेक टाइम।
Hello? Three and a half.
3.5 इसमें आएगा 3.5.
Okay. Hello, class. A very good evening. We are going to study the anatomy of the angle today. What is this angle that I'm talking about? I'm talking about the iridocorneal angle. This looks so complex, right? But I have done all the work for you. Don't worry. Now we are going to put all the pieces together one by one. Are you ready? So, we have the cornea and the sclera meeting at the limbus, and the inner surface of the limbus has an indentation called as the scleral sulcus. The sharp posterior margin of this scleral sulcus is called as the scleral spur. What is attached at the scleral spur? Yes, it is a longitudinal ciliary muscle which is part of the ciliary body. This converts this entire region into a dynamic region. Now we find that the iris is also attaching to the ciliary body. The attachment is at the root of the iris, and you have this band-like structure between the scleral spur and the root of the iris. This is called as the ciliary body band. Now notice that I have marked scleral sulcus and the Schlemm's canal at the same area. How is that possible? That is because this space created by the scleral sulcus is covered by this lid-like structure called as the trabecular meshwork, and that converts this entire region into a dynamic tube called as the Schlemm's canal. The Schlemm's canal then opens up into various outlet channels, which we'll be talking about later. Now, talking about that lid, the trabecular meshwork. The trabecular meshwork has an anterior non-functional part. We're not going to talk about it. Now, it has a posterior part which is divided into 3 layers. We have the juxtacanalicular trabecular meshwork, which is closest to the canal, the Schlemm's canal, and this offers the maximum resistance. It has the smallest size pores. Next up, we have the corneoscleral trabecular meshwork, and lastly, we have the uveal trabecular meshwork, which is closest to the iris tissue or the uvea. Now, I made a video summarizing all of what we've learned today, and just notice one thing. All 3 layers of the trabecular meshwork seem to form a funnel-like structure. That is exactly how it works for the aqueous. Now, coming to the outlet channels, from the Schlemm's canal, the aqueous empties into the episcleral veins through a direct pathway or an indirect pathway. The direct through the aqueous veins of Ashur, or the indirect through the scleral plexus. From the episcleral vein, it goes into the superior ophthalmic vein and finally into the cavernous sinus. I'm sure you would have seen this image so many times, but now you actually understand this image. You have the Schwalbe's line, which is a peripheral termination of the cornea, the trabecular meshwork, and the scleral spur, and lastly you have the ciliary body band. You know that the trabecular meshwork, the posterior part, is a filtering region. So if that is open and visible, the angle is open. And if that is not visible, the angle is closed. We covered the what, now how. We have a lot of modalities such as gonial lenses and AIOS2025, and finally I'm going to leave you with some homework. Anyone who can find out what this phenomenon is going to get a chocolate from me tomorrow. Hope you had a lot of fun learning. I had a lot of fun teaching. Thank you.
Excellent. I think the judges, no questions. You can please mark if you finished well within time. No, this is the Vokes trio, number 2. Wizards of GNEC? No, you are Wizards of GNEC, no?
Yes, sir.
Okay.
Hello.
Where is the broom? Now we're going to start Quidditch, okay? अरे कोई हेल्प करना यार. Some muggle, please come and help the wizard. हॉगवर्ट का लैपटॉप कुछ अलग होता है. हैं? Harry, you forgot the chant, huh?
Hello. Hello. Hello.
Yeah, start.
Morning, Hogwarts. So we will be studying about iridofungal coloboma. So what is coloboma? Coloboma actually is Greek for mutilation. It is actually a defect in the ocular tissue, and it can be of two types, either typical involving the inferior nasal or inferior part, or atypical involving the defects elsewhere. So what's the embryology behind it? So the optic stalk and the optic cup develop from the forebrain. And if we look closely at it, we can see that inferiorly it has an opening which is called the choroidal fissure. Now, if we can see on the cross section even closely that the choroidal fissure is inferiorly open and normally closes by 5 to 7 weeks, but if it does not close, it forms a coloboma. The most common genes associated are the SSH gene and the PAX2 gene. And the most common syndromic association is with the CHARGE syndrome. So, what do the patients complain? The parents may say that there is some abnormality with the child's eye, but they may not be able to understand it. The child can also present with a diminution of vision. It can also be asymptomatic if the coloboma is peripheral in location. The child can have clinical features of nystagmus. There can be an associated microcornea or microphthalmos. Orbital cysts can be associated. The patient on anterior segment examination can have a iris coloboma, a ciliary body coloboma, a cataract, which is usually hard nuclear sclerosis in these cases, a fundal coloboma on the posterior segment examination, a choroidal neovascular membrane at the edge of the coloboma, and a scleral fistula can form even on minor traumas. Edelman classified the posterior fundal colobomas on the basis of extent of involvement, the type 1 extending above the disc, type 2 up to the superior margin of the disc, type 3 up to the inferior margin of the disc, type 4 involving only the disc, type 5 having a normal retina above and below the coloboma, type 6 having a periphery pigmented lesion also called as form fruste lesions, and type 7 involving only the periphery. So, which other classification do you know of? There is also a classification called as the Lingam-Gopal classification. I want you all to read about it. We will discuss it in the next class. Now, what's the concept behind colobomas and the related RDs? So, the normal retina at the edge of the coloboma forms a fibrous membrane, turns into intercalary membrane. And at the junction of the coloboma and the normal retina, it is attached. At this point is called as the locus minoris resistentiae. Now, if we want to understand the association of RDs and colobomas, three dehiscence must be seen. First, a break in the retina. Second, a dehiscence in the locus minoris resistentiae. And third, in the intercalary membrane. So let's consider the first case in which there is a break in the intercalary membrane and a break in the locus minoris resistentiae. So the fluid will go through the break, cause an ICM detachment as well as a rhegmatogenous retinal detachment. Now this is because of the coloboma, so it is called as a coloboma RD. In case 2, we have a break in the ICM, but there is no break in the locus minoris resistentiae. Therefore, the detachment will be only of the ICM. It will not lead to a retinal detachment. In case 3, we have a break in the retina, whereas there is no fluid elsewhere. So, it causes a retinal detachment like a coloboma is associated with it. And in type 4, there is a retinal break and associated locus minoris resistential break. So, it will cause a detachment of both the retina as well as the locus minoris as well as the ICM. Management is by pars plana vitrectomy with siliconal insertion, as there are high rates of buckling failures, and a prophylactic laser barrage or the margin of the coloboma is necessary. Also, prophylactic laser barrage of the coloboma margin, 2 to 3 rows must be given in all cases. The main difficulties faced are that if the coloboma involves the macula cannot be lasered. We will have to leave it as such. And if it involves the functional margin of the disc, we will have to give very light burns. Thank you.
Thank you, Professor. I'm sorry, all these Slytherins sitting here will cut 1 mark because you overlasted the time, but you are excellent. Thank you so much. I think a round of applause for Professor Dumbledore. And the Wizards of GNEC, please take your... Okay, that is SGN Pandits. Okay, then A train. There. I think we need to avoid these time delays. We hardly have any time.
Sir, KP sir.
So we can keep
so
the
the
next one
timer
ready,
part-
sir.
Okay, then start with Moria's Master Blasters first.
Sir, for him, so it will be, timing will be 0 or it will be minus?
Zero,
1?
zero.
0, that's all.
No,
Not
you don't
minus.
give marks for that. Zero.
No, 0.
No negative mark. What's this for?
That is for props.
Hello, hello, mic check. Hello, am I audible? Okay. With a quick show of hands, how many of you think this patient has proptosis? Maybe worms view will help you appreciate the proptosis in right eye. But how much? Is it lesser or more than the previous visit? This is exactly why we need exophthalmometry. So class, here's Coach Kabir Khan with his timeless charm to grab your attention for me. And I'm Dr. Banka Meghajai to discuss everything we need to know about exophthalmometry. Now we are all aware that proptosis is abnormal protrusion of the eye. And exophthalmometry is the measure of the distance from the lateral orbital rim to the corneal apex in the eye, with the eye in the primary position. Now, exophthalmometry not only objectively quantifies proptosis as a measure of more than 20 millimeters or a difference of more than 2 millimeters, but also grades its severity as mild, moderate and severe. But why measure at all? To have an objective absolute reading, to differentiate between proptosis and pseudoproptosis, and lastly to monitor progress. Now, clinically, exophthalmometry is measured with our go-to tool, the exophthalmometer, which is available in various shapes and forms. Now, before you develop proptosis looking at all these names, let's shift focus to the 3 commonly used exophthalmometers. Here we have Dr. Farnaz, my senior fellow. I promise I won't poke you in the eye. When using the Hertel's exophthalmometer, have a direct source of light in front of the patient and align your eye level to the patient's eye. Engage the foot plate on the lateral orbital rim of the patient on both the sides and ensure the base reading on the scale and note it down. Then when checking the reading in the right eye of the patient, tilt to your left and look for the 2 lines on the prism and ensure that they coincide as one line. Close your left eye and check for the reading coinciding with the corneal apex as seen by the yellow arrow on the slide. Now repeat the process for the other eye. If this is how you look when you take your reading, you're probably doing it right. When recording the reading, denote the reading with H, which denotes Hertel. Note the base reading in the bracket, which has to be maintained in every follow-up visit to minimize observer variation. The reading in the right eye with the upper arrow and the reading in the left eye with the lower arrow. Now, when in case of abaxial proptosis, Hertel's has to be supplemented with McCoy facial tri-square. But after a quick OCA check from the hospital administration, we all find our way back to the good old ruler. Place one ruler on the nasal bridge straight. With that as the base reference, check for the difference in the vertical distance of the pupillary difference between the 2 eyes, which denotes the amount of hypo or hyperglobus. Lutz is a cheap and easy to use exophthalmometer, while Noggle is useful in cases of trauma where the lateral orbital rim is not intact. Halal and Trokel is a radiological method where a mid-axial cut at the level of the lens gives the amount of proptosis by the difference in the perpendicular lines drawn from the corneal apex to the line joining the zygomatic arch. In case of vascular orbital tumors, always repeat exophthalmometry with Valsalva maneuver, wherein we check for increase in proptosis with the patient blowing in their mouth with their nose pinched, or for after making the patient bend down for 5 minutes. An increase in exophthalmometry in case of thyroid eye disease indicates an increase in clinical activity score, worsening of inflammatory orbital lesions, optic nerve lesions, or vascular orbital tumors. From this point on, I hope you'll never guess, but always measure and confirm proptosis and enophthalmos. Practice till you get comfortable. Rule out pseudoproptosis. Always repeat exophthalmometry for vascular orbital tumors and track progress. Well, I could go on and on, but maybe I'll take your leave with these words of wisdom from Mrs. Gangubai Kathiawadi. Thank you.
Can you have the next person from SGN Pandits?
Can we even ask the next one to get ready, sir, there? Next in the line.
ये वाला खराब है.
अच्छा, खराब है.
नहीं तो मैं भी प्रेजेंट करता. ये train is, yeah, you are next there, be ready. Okay, subsequently we will have Oculo Catalyst, then we will have Iconic Trio, then we will have IQ TOTs, Then we will have the Pink City optic nerds. Be ready in that order.
सर हमें नंबर बता देना.
Next, after 8.
अभी 4 है ना.
So this is 4.
This is 4. Yeah.
This is SGN Pandits.
कुछ पिंक सिटी नर्ड्स तो नहीं मिला मुझे. यहाँ है.
This is a play.
Students में senior.
Eyes are a gift through which you can see the beautiful world. And imagine not being able to see through. We are going to talk about one such disease, retinitis pigmentosa. So the rods are concentrated in the periphery and the cones in the center. When I say retinitis pigmentosa is a rod cone dystrophy, it means that the night and the peripheral vision is affected first, followed by the central and the color vision. It affects 1 in 5,000 and it can either be sporadic or inherited in autosomal dominant, recessive or X-linked recessive manner. The rods have various genes. Because of mutations in these genes, there is apoptosis of the rod cells. Just as single rotten apple spoils the entire basket, similarly, these dead rod cells would create a toxic environment for the surrounding cone cells and lead to their destruction as well. The classic triad is pale optic disc, thin blood vessels, and bony spicules. Now, because of the constant death of rods and cones, the demand for oxygen is less, and hence there is vasoconstriction or thin blood vessels. Retinitis. Itis means inflammation. There is a notion to link RP to inflammation. So this inflammatory process causes proliferation of glial tissue on and within the optic disc, giving us a pale optic disc. And the bony spicules are degenerated RP cells. Whenever evaluating a patient, you have to ask for systemic symptoms. If associated with hearing loss, it is ushers. If with obesity polydactyly, it is Bardet beetle. Now the dark adapted predominantly tests your rods and the light adapted tests your cones. So initially you can see only the rod response is affected, whereas the cone is relatively normal. Only in advanced stages the rod as well as the cone response is blunted, which shows that RP is a progressive disease. Now already in the patients of RP, we have a constricted field, or what you call as the tunnel vision. Moreover, they have a tendency to develop PSC cataracts, which can be even more devastating for them. Removing the cataracts shows an increased incidence of cystoid macular edema. So my question to you, should we remove the cataracts or not? So students, we have to counsel the patients about the risk, but also tell them that if the cataract resolves or does not develop, they would probably be the happiest cataract patients. Can we treat RP? The inquisitive nature of humankind has made the impossible possible. These are our happy patients post low vision aids. One of the genes mutated is RP65, which when incorporated into an adenovirus vector and injected subretinally has proven wonders. Can you imagine the agony of the RP patient who was able to see and now not? So students, while treating RP, you not only have to treat the eyeballs, you have to treat the whole patient as well as his family. The ongoing genetic study is helping us map the mutated genes which can be targeted during gene therapy. I'm sure in times to come, we'd confidently be able to treat this seemingly untreatable disease. Thank you.
See, when you have RP, you lose the peripheral vision, that there's a time, or in the periphery there's a time which you lost actually. Sorry, you were obsessed with, I don't know, judges can take a call. So, do we have the A-train people there? Yes. A-train, yeah. Next is DDU dynamos, followed by oculocatalyst. So just to finish things quickly, we have a second set of judges also. We are going to the 1/3 of the candidates will be shifted to the next hall, that is trade hall 4, in some time, in another 15 minutes, so that we can have a parallel session there.
So this is not.
Start from the beginning.
Everyone knows the importance of yoke muscles. Good evening, I'm Dr. Anahita on behalf of A-Train. There are 6 main muscles that are responsible for eye movements, the 4 recti and the 2 obliques. Because of the way the muscles are placed, the superior and inferior recti act when the eye is abducted, whereas the obliques act mainly when the eye is adducted. So how do we check the cardinal positions? You simply draw an H in front of your patient and ask them to follow your finger. So by this method, you can see all the 6 cardinal gazes. We call them cardinal because one extraocular muscle is the prime mover of each eye in each of these 6 positions. Conjugate movements are movements where both eyes move in the same direction. Yoke basically means the wooden structure that is kept on cattle so that they can pull heavy loads together and work in tandem. Deriving from that, yoke muscles are a pair of muscles, one in each eye, that produce conjugate movements and work in tandem. So how to remember these? We all know the lateral gazes are quite easy. For example, dextro version, we know that the right lateral rectus and the left medial rectus are acting, and vice versa for the levo version. The other 4 cardinal gazes can be a bit tricky. We know that in levo elevation, recti act when the eye is abducted and obliques when the eye is adducted. But I will give you a simple trick to remember the same. Levo, you think left. Elevation, you think superior rectus. And then just invert each alphabet. Left becomes right, superior becomes inferior, and recti becomes oblique. Thus, right inferior oblique is the yoke muscle pair for this movement. Similarly, for dextro depression, we know that dextro is right. Depression, think IR. And just invert all of this. Right is left, superior, oblique. And thus, we get the yoke muscle pair. Now, I want you guys to answer. Tell me, what is dextro? Yeah. Elevation is? And let's invert all of this. Very good. So now all of us are masters at yoke muscles. So Herring's law of equal innervation states that equal neural signals are sent to both yoke muscles to ensure coordinated binocular eye movements. This is important in nerve palsies. Here you can see the left eye is primarily deviated a bit. But when we force it to take up fixation, it will draw extra impulse because the muscle is weak. This extra impulse will also transfer to its yoke muscle, causing an excessive medial movement. Therefore, in palsies, the secondary deviation is always more than the primary deviation. So now we know the magic behind these movements. We hope it helps you diagnose, evaluate, and manage motility disorders. Thank you.
We still had time. You could have shown some more movie clips actually. You started also 10 seconds late. They would have given
We
extra
kept a
marks.
buffer, sir. We didn't want
That
to
was a buffer. Okay. So,
A-train.
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 A-train, yeah.
A-train.
It was a A-class training for all of you. And we have DDU Dynamos. I think a clap for Dr. Anahita. See, you should clap for your friends. Fantastic. Hope we had such teachers when we were studying. With all that movie clips, I'm saying.
We missed out in our times.
Oh, movie nahi tha. Yes, yes. See, all the real teachers have to take lesson from these newbie teachers. Yeah, over to you.
Dynamos.
Good afternoon, everyone. Are you ready for the class?
Yeah.
I'm going to discuss test of stereopsis. But before going to that, we should know what is stereopsis. So stereopsis is the perception of depth which we get due to the image disparity between the two eyes. What are the tests? These are the tests. First of all, a gross test, Lang's 2-pencil test, We put one pencil upon another. If the patient can do it better binocularly, he has good stereopsis. But if he has no difference between a uniocular movement or binocular, the stereopsis may not be good. Then we have Frisbee stereo test. What is this test? It has three plates of different thickness. All plates will have 4 squares. 4 squares would have different random signs, and then in the 4 squares, one square would have a circle. If the patient can identify the circle, then the patient would have stereopsis according to the plate. If he can identify upon 6 mm, 340 seconds of stereo acuity. If 3 mm, 170 seconds of stereo acuity, and 1 mm, 55 seconds. Then we have the Lang stereo test. Lang stereo test, we just show the patient a plate. If the patient and we ask him to identify 3 objects, if he can identify that, the patient would have good stereopsis. A car is for 550 seconds stereo acuity, star is for 600, and cat corresponds to 1200. Then we have the TNO stereo test. We ask the patient to wear red-green color glasses, and then we give them 7 plates. The first 3 plates are for screening in preschool children, to screening for stereopsis. These are the first and third plates of the TNO stereo test. The fourth plate is for suppression test, and the 5th, 6th, 7th will give you the quantification of stereo acuity. 5th plate would correspond to 480 to 250 seconds of stereo acuity. Plate 6 would give 120 to 60 seconds of stereo acuity, and plate 7 would give you 30 to 15 seconds of stereo acuity. This is the Titmus fly test. This test and the next test we will discuss are based on the principle of linear polarization. We would make the patient wear Polaroid glasses. One would have a horizontal filter, one would have a vertical filter, and then we will ask the patient, can you see the wings of the fly? The patient would try to catch the wing. If the patient catches the wing above the plate, he has good stereopsis. But if he tries to touch the plate, he has bad stereopsis. Then we come to this 3 rows of animals. We ask the patient, can you see any standing up animal? If he presses that animal, he has stereopsis corresponding to that, and there are 9 boxes which will have 4 squares. If he can identify which circle among the box is standing out, the stereo acuity would be corresponding to the box. This Randot stereo test, very much similar to the Titmus fly test. Just in place of the fly, we have 2 groups of 4 squares, and the patient is asked to identify objects in this squares. If you still can't remember these tests, I'll have a mnemonic for you. Lazy frogs love to try racing. And if you still cannot identify it clinically, just go out and ask the patient to catch a ball or thread a needle. We can also have driving simulation tests in older people. These are the experimental tests, virtual reality stereo tests, and functional MRI studies. Thank you very much.
So that was a very dynamic presentation from the DDU Dynamos. Oculo Catalyst will be next. I'll call the next 3 to be ready. Some iconic trio. You are there? Iconic trio. No. Then IQ Tots. Okay. Then Pink City Optic Nuts. Yes. Then Indocyanins. That is the order next. Okay.
So this is Oculo Catalyst.
Oculo Catalyst number 7.
Good evening, class. Can you take a guess on the topic on these pics? Is the first kid feeling sleepy or the second child just giving a wink? It's not the pathology we'll be discussing here. It's the culprit. It's your levator palpebrae superioris. As the name says, levator, it elevates. Palpebrae is the Latin term for your eyelids, and superioris is upper. It's basically a muscle of your upper lid. In this, we'll be seeing its embryology, anatomy, and its clinical implications. Embryology, as any muscle tissue, it has its mesodermal origin, and this, along with the superior rectus, belongs to the second pharyngeal arch group of muscles. Structure, it is basically a triangular or a ribbon-shaped muscle located between your fibrous tissue plate and the conjunctiva. And its origin is from the lesser wing of sphenoid, unlike any other extraocular muscle, which has its origin from the annulus of Zinn, and it has a long horizontal course followed by a vertical bend, which is marked by your Whitnell's ligament. This Whitnell's ligament is just basically a condensation of your orbital fascia, and it acts like a pulley. This is because of which the levator palpebrae gets a elevating action rather than an anteroposterior action. And this is important because severing of this ligament in ptosis surgery can lead lead to loss of its LPS action. Insertions can be anteriorly. It is important as it gives the skin fibers and forms the lid crease, and posteriorly it goes into the superior fornix and also into the tarsus. Medially and laterally it goes into its respective canthal tendons. This crease is important in knowing your ptosis. In case of congenital ptosis, the pathology is the muscle is dysgenetic, so the crease won't be there. Whereas in case of senile ptosis, the pathology is that the muscle would have been atrophied, which has led to the higher lid crease insertion. Nerve supply is basically by the superior division of the oculomotor nerve, which is a nuclear complex located in your midbrain, but the LPS subnucleus is single and caudally located. So any lesion at the nucleus or supranuclear level will lead to bilateral ptosis and other features of third nerve. It follows Hering's law. So it helps to differentiate ptosis and pseudotosis. In case of any ptotic lid, if you retract the ptotic lid, there should be drooping of your contralateral lid. If this also helps in planning your ptosis surgery, whether it could be unilateral or bilateral, for better cosmosis. Blood supply is majorly by the lateral muscular artery, a branch of internal carotid artery. What is synkinesis? Synkinesis is when you move on your oral movements leads to elevation of your ptotic lid. This is significant when the elevation is more than 2 mm, and it is basically due to aberrant regeneration of your trigeminal nerve in the levator palpebrae muscle. And we'll go for surgery in cases where there is severe amblyopia, vertical strabismus, and severe ptosis associated with Marcus-Ganjoff phenomenon. Why is it important to know the function and its grading? This helps you plan the type of ptosis surgery and the amount of resection to be done. LPS grading is done by measuring the amount of excursion from down gaze to up gaze by negotiating the action of frontalis, as you could see here, by placing your thumb. The amount of resection is that 1 mm of ptosis correction needs 3 mm of resection, and for a resection to its average effect, we need minimum 8 mm of resection. Anatomical variants that has been described include biparietate muscle and accessory muscle slips. These muscle slips have been found to roll in congenital lid retraction and blepharoptosis. As a take-home point, origin is from lesser wing, insertion as 5 insertion, landmark is Whitnell's ligament, nerve supply is your oculomotor nerve, function elevates the lid, and clinical implication is in ptosis and ptosis surgery. Thank you.
Okay, excellent oculocatalyst number 7. Now we have the IQ TOTS, followed by the Pink City optic nerds. And next will be the indocyanins after that.
IQ, number 8.
This is number
9.
this is number 9. There is no number 8. Number 9.
8 is
8 is not there.
8 is not there, 9 there.
This is the 9 one.
This is the 9. This is 9. IQ TOTs.
Good evening, class. Today I'll be discussing about ocular manifestations of Behçet disease. Initially it was called a disease, now it's been retermed to syndrome. I am from IQ TOTS, AIMS Raipur. Going into a bit of background, Hulusi Behçet was a Turkish dermatologist who followed up these patients and noticed a triad in these. A patient with recurrent oral ulcers, recurrent genital ulcers, and hypopyon uveitis. After him is what the disease is named. The disease is common in old Silk Road population from Japan to East and from Japan to Turkey, and maybe because of the population having more number of HLA-B51 genes. It is common in 2nd and 4th decades, and males having more preponderance in terms of ocular manifestations. We use the ISG, International Study Group criteria, for classifying Behçet disease. It tells having recurrent oral ulcers plus any two, say skin lesions or eye lesions, we can classify the patient into Behçet disease. As per the recent Sun classification, a compatible Behçet uveitis syndrome can have anterior, posterior, intermediate, or a combination of any of these in a patient who satisfied the ISG criteria. Now, after reading all of this, maybe we are ready for a little quiz question. So, which of the following do you think patients has Behçet disease, A or B? We have chocolates for anyone who answers. So, the answer is A. This is classically Behçet uveitis has cold hypopyon compared to its close differential diagnosis, which is HLA-B27 uveitis, which has hot hypopyon. Behçet also has more bilateral and less ciliary injections compared to HLE-B27 uveitis, and because it is rarely fibrinous, what we notice clinically is the hypopyon is transient, it's shifting or fleeting hypopyon. Hypopyon might even not be so marked that we might have to see it on gonioscopy sometimes. Another manifestation is diffuse vitritis. It is acute, it is recurrent haze and might resolve even without treatment and sometimes. It might also have small inferior precipitates, also known as posterior precipitates or posterior KPs, but they are different from snowballs. As in, snowballs are a bit larger. These precipitates are smaller, and once they heal, they form a linear pattern. We also have cloud of cells in the vitreous. Another manifestation is repeated retinal vasculitis. The vaso-occlusive episodes cause recurrent hemorrhages, and over the time, they create capillary non-perfusion areas on the FFA. We also have superficial retinal infiltrates with retinal edema, as seen an associated artery and venous segments hyperfluorescence, which may resolve by spontaneously, leaving behind ghost vessels, and years later resulting in atrophy of inner layers. Here's another question for you. A 30-year-old male, Nonglal, he is a known case of Behçet syndrome. He came to us with blurring of vision. Past history of repeated entry bouts of entry uveitis was there. And clinically, the fundus was relatively okay, not significant. On angiography, this is the picture we had. Anyone can tell what's the angiographic appearance for this? There is another chocolate. So, if anyone, yeah, so the class answer is fern tree appearance of the Behçet uveitis because of diffuse retinal vascular leakage or late staining. End stage might mimic RP. Treatment is immunosuppression, steroids, steroid-sparing agents. Thank you. These are the notes, QR code.
So that was IQ Tots number 9. Now we have Pink City Optic Nuts, which is in the second page 79. That will be followed by Indocyanins. And next it will be Visionaries, then Eye Opener, then Corneal Crusaders.
17.
अब कौन सा भी तुम्हारा कौन सा ये इंडोसाइनिन है यू आर इंडोसाइनिन
No,
No,
no.
ma'am. Pink City Optic.
79.
A very good afternoon to everyone. Greetings from Pink City Optic Nerds. Today we'll try to answer some questions related to amniotic membrane grafting. So starting with what is amniotic membrane? It is the innermost layer of placenta which consists of 3 layers, epithelium, basement membrane and a compact stromal matrix. Talking about the history of amniotic membrane, it was D. Roth who first documented the use of live fetal membrane in conjunctival reconstruction, followed by innovations from other scientists like Brown and Salisbury in the early 1940s. It was Kim and Seng in 1995 who ultimately reintroduced the idea of amniotic membrane for ophthalmic use. So where in the eye is amniotic membrane used? So it has a variety of indications in the eye, primarily involving the cornea and ocular surface reconstruction, with its most life-altering use in ocular surface burns and cicatrizing conditions like Stevens-Johnson syndrome and symplepharon. Now, what makes the amniotic membrane so useful in the eye? It is its unique biological properties, as it is a source of stem cells, growth factors and cytokines. So this lends it to its anti-inflammatory, anti-scarring, antimicrobial and anti-angiogenic properties. As it is low in immunogenicity, so the risk of rejection is minimal and it promotes epithelialization. Now, due to the limited shelf life of the fresh membrane, deep storage issues of the cryopreserved membrane, the dehydrated and the lyophilized freeze-dried forms are the most widely used commercially. Now, I would like you all to have a look at this video. So here we can see the placement of amniotic membrane. It is placed as a single layer over the cornea. This is a case of acute chemical injury. So this is the kind of grafting technique known as the onlay or patch graft. The other one is inlay, in which the defect is filled with multiple layers of amniotic membrane and the epithelial side is kept up. The third one is sandwich technique, in which it is a combination of the other inlay and onlay patch. So what is slit? Can anyone answer this question? Yes, it is simple limbal epithelial transplant, which is it indicated in unilateral limbal stem cell deficiency. In this, pieces of limbal stem cells are placed over the amniotic membrane and then placed over the ocular surface. So along with the conventional methods like sutures and self-adhesion, the other methods which are commercially available for the fixation of amniotic membrane are tissue adhesives like cyanoacrylate and fibrin glue and amniotic membrane rings. Every surgery comes with a complication, so complications comes with amniotic membrane transplantation, but they are very minor. Cost limitation is minimal, but the major limitations of amniotic membrane grafting are surgical only. So in a recent study, the specialized bandage contact lens has been used as a method of delivery of dehydrated amniotic membrane in dry eye disease in a recent paper. And bioengineered synthetic alternatives like known as cymatics membrane have been developed in vitro and studied extensively, and the results are found to be comparable to human amniotic membrane. So can anyone think of any novel intraocular use of amniotic membrane? Yes. So in macular hole, it has been used in macular hole surgeries, and it is also used in surgery, glaucoma surgery, especially in overfiltering trabeculotomy flap. So thank you all for your patience. Doubts, if any, are welcome. Thank you, ma'am.
So that was 79. We now come back to indocyanins number 10. Indocyanins are here? No, not. Visionaries? What happened? Eye openers? You are what? Which visionary you are? There are too many visionaries in ophthalmology. Which you have?
Capital visionary, small visionary.
Okay, we can come to know who it is by the mentor name anyway.
Visionaries.
No, you present, no problem. If you are a visionary, you are most welcome. Eye openers? They have closed their eyes. Corneal crusaders? Okay, no crusades. Udaipur Royals? Upside down? What is this? हाँ.
कौन सा है? उदयपुर रॉयल 14 सर. 14 नंबर. नहीं उदयपुर रॉयल.
Udaipur Royals, which is number 14.
All right, settle down class. We're going to learn about corneal scraping today, which is an essential tool for a comprehensive ophthalmologist. Why is it essential? Because history and clinical features, they give us a clue about what the diagnosis might be, but scraping gives us an accurate diagnosis. And culture is also the gold standard for microbial keratitis. Indications, according to American Academy, are a central large infiltrate with or without stromal involvement, chronic or refractory cases, previous history of corneal surgeries, atypical clinical features, and multiple corneal infiltrates. Equipment that we need are some blades or either a Kimura spatula, slides, cover slips, and inoculation media, and some anesthetic eye drops. Before the procedure, we need to ensure that we withdraw the antibiotics for at least 24 hours. Use of preservative-free anesthetic drops is advocated because preservatives actually decrease the bacterial viability. Proper documentation in the form of photographs and corneal drawings has to be made. Explain the procedure nicely to the patient. Reassure the patient to ensure complete cooperation. So when we start doing the procedure, we get rid of the loose necrotic tissue and the debris, as this might result in a negative culture. So we start scraping from the leading edge of the ulcer and then followed by the base of the ulcer. The blade is kept perpendicular and the direction has to be similar, like you don't have to go to the entire area. You make scrapings in a single direction. Samples are transferred over slides first for KOH and gram stain, followed by inoculation of the culture media. Now, inoculation of the culture media, as shown in the photograph above, has to be made in C streaks, and each C streak, every time you make a C streak, you use a new blade and a new sample every time. Blood agar and chocolate agar are solid medium, but liquid medium can be used according to different scenarios. In difficult situations such as pediatric or uncooperative patients, we can do it under general anesthesia. In cases of desmetocele, we can plan scraping and followed by glue BCL. A deep-seated ulcer can be accessed by a braided suture pass or a skin biopsy punch and refine. Endothelial plaques can be accessed by a paracentesis and a needle. These are some photographs of these scrapings. These are the various types of stains used in different scenarios. Negative smears can be seen in cases of prior use of antibiotics, insufficient samples, necrotic sample as I said before, poor staining techniques, failure to scan the whole slide, excessive heats, fixation, and mechanical damage to the cell wall, as gram staining is dependent upon the cell wall of the bacteria. These are the different types of cultures. A negative culture can be seen, again, prior antibiotic therapy, false interpretation of the culture, inappropriate selection of the medium or the method used, inadequate sampling methods, and of course, sterile non-infectious ulcers. What is the role in therapy? When we do scraping, it decreases the organism load. While decreasing the organism load, it also aids in the penetration of the drugs. Debridement and maintaining globe integrated integrity in cases of impending perforation can be also seen. So to summarize, why do we do it? Because it is the gold standard. We can identify the organism and we can tailor the treatment. When do we do it? When there is a large infiltrate with atypical features or multiple infiltrates, history of corneal surgeries, and ideally scrape before starting the treatment. How do we do it? We document and counsel the patient. Topical anesthesia, blade or a spatula. We scrape the edge or the base. New blade is used every time. Scraping is done in one direction. Proper marking of samples. And take care contamination does not occur. Thank you.
Can we have the upside down now? Is he coming from the top? No. Then we have New Horizon. Okay. I teach. Yeah, please. Next will be cortical chasers. Are they there? Okay. Please. This is ITG 17.
Maybe 17. इसके बाद आई.
This is I-Tech.
I teach.
I teach. चाय की बहुत ज़रूरत है. Myopia होता है, चश्मे के बिना आंसर लिखेगा.
Who has done this mistake? You are teacher of
It was there in the main
teacher of past actually. That's why you made mistake. You please continue.
तो ऐड कर देंगे ना. So somebody came and added that. Your girl, I think, must have added. One girl came and added one name. I just went out.
Team RIO PGM Rohtak.
ROP Gems. RIOP Gems.
So one lady, one girl came and added RIO Rohtak का.
17 try 17.
हम बिल्कुल करेंगे.
तुम I teach हो?
हाँ भेज दूँ.
Yes, ma'am. Yes.
This is from the horse's mouth.
Hello.
ये हमें रेसिस भी हैं.
Yeah. It's given.
साइट सीकर्स भी हैं, साइट सेवर्स भी हैं. साइट सेवर्स भी हैं. साइट सर्वेंट्स.
Servants.
Okay, ठीक है. Okay, call me. I'll send.
मैंने इनको कहा कम से कम चाय पिला दे.
टीचर टॉफी दे रहे हैं, नाम ले रहे हैं, चाय पिला रहे हैं.
Next maybe.
कहाँ है?
Why you are not loaded?
Message
We've given, sir, already. It's not available. I submitted, sir, already.
So by then you can load there and we can call the next person. I think you can.
Cortical chasers.
This one only.
बस आप लोगों से एक इधर आके करो ना कुछ.
Good afternoon, everyone. Today we'll be discussing on Tyrian marginal corneal degeneration. First, let's decode the name Tyrian. It was described by French ophthalmologist Dr. Félix Tyrian in 1990. It is a slowly progressive condition resulting in peripheral corneal thinning. Included in the degenerative category, initially it was thought to be non-inflammatory with few inflammatory variants in younger age group. Coming to the epidemiology, it is bilateral, symmetrical, but could present in asymmetrical also, with the disease occurring in the second eye decades after first, and it is commonly seen in age group of 20 to 40 years of individuals with a higher male preponderance. Coming to histopathological evaluation, it reveals that the epithelium is intact and thickened, and there is absence of Bowman's membrane or degeneration of the Bowman's membrane with subepithelial fibrillar collagen degeneration associated with stromal thinning. Occasionally, there may be descendant membrane breaks.
There are two variants, namely the classic variant, which is seen in older patients, asymptomatic, non-inflammatory, and it is slow and chronic progression. The other variant is inflammatory, which occurs in the younger age group. It is painful and it is associated with scleritis and episcleritis. It has faster progression. Coming to the clinical presentation, the lesion usually begins as fine punctate opacities supranasally and then proceeds circumferentially. It is followed by superficial vascularization from the limbal vascular system. Then there is associated stromal thinning and there is deposition of yellow-white lipid deposits at the leading edge. And then there can be the formation of pseudopterygium, which is a flat, broad-based lesion which is developing in the oblique axis. Perforation is rare but can occur spontaneously or following a minor trauma in 15% of cases. The disease usually progresses in 5 stages, with stage 1 having only an opaque band superiorly, later on involving the 360 degrees in stage 5. The condition is asymptomatic, but gradually it can cause a deterioration in the vision due to the development of against the rule astigmatism. The condition is usually a clinical diagnosis, but we can see a reverse crab claw pattern in the pentacam, and the AIOS is showing the characteristic morphological change with the epithelium intact. We should know how to differentiate it from the other conditions. Coming to Dellen is a localized corneal thinning with no vascularization and lipid deposits. Next is the Murren's ulcer, which is a painful ulcer, and it has an associated epithelial defect. And then there is furrow degeneration, which is bilateral and it is avascular. And then we have the pellucid marginal degeneration, which is the inferior ectasia. Coming to the treatment, medical treatment involves educating the patients to avoid eye rubbing and using protective eyewear and spectacle corrections. And we can use rigid RGP lenses and scleral contact lenses, and we can also use PROS. Surgical treatment is indicated in patients with impending perforation. We go in for tectonic surgeries in order to maintain the structural integrity of the eye using conjunctival flaps or scleral grafts. And then we can also perform vision enhancing surgeries like partial or total penetrating keratoplasty. Even if you are inattentive till now, kindly take a note on this slide. Terence marginal degeneration is a condition which results in peripheral corneal thinning, and it has two variants, with slow being the classical one occurring in older individuals, and the fast progression is the inflammatory variant occurring in the younger individuals. And it causes high against the rule astigmatism, with the lesion being superior, and we can map it out with the reverse crab claw pattern in the pentacam, and we can use the spectacles and also protective eyewears to protect ourselves from the condition.
Thank you, I teach. Now we have the cortical chasers. Okay. So I'll be telling the names of the teams who are going to be shifted to the trade hall 4. It's all getting ready. You all can probably shift now. Icon mentors, incomplete, synergists, classroom catalysts, glowing Gadak, team Iconica, Jedis. You can leave to trade hall 4. Here it's going to start. The judges are already ready there. Avengers, Teaching Titans, Guru Shishya, SCB Odisha, Progressive Pioneers, Mavericks. Nobody's here? Arey jao yaar. Trade Hall 4, there's a parallel session of you people, all the judges. Hello. Should I send once again? No.
Sir, kya do?
Icon mentors, incomplete, synergists, classroom catalysts, glowing Gadak, team Iconica. You're all very happy, I know. Jedis, Avengers, Teaching Titans, Guru Shishya, SCB Odisha, Progressive Pioneers, Mavericks, Visionaries, RIO Rockstars, IQ Experts, Visionaries, one more Visionaries, and MGM IQ, iConquer, Iconic, third Visionaries, Vitrio, Vitis, AFMC, Gen Z Teachers, Pupil Professors, Jupiter Gurus, Team VK Vision Keepers, IQ Crew, Mavericks.
There are two Mavericks.
No, there are two Mavericks here.
Yeah, both of them are. Team RIO PGM.
Thank you for
All right,
Don't do a rent,
I'll send. Huh?
Yeah, can we start?
नहीं नहीं अभी आजा सब लोग गए अभी already. Just ask them to quickly finish.
Timer reset.
Let them sit, no problem.
Timer you have to reset.
Force them to call. Ask them to.
Timer reset.
Timer reset कर दो भाई.
Reset कर दो. हाँ.
3.5 ना?
Just hold your horses. This is the
Cortical chasers.
This is cortical chasers. So symbiotes, vanquishers, vanquishers, they vanquished. Amer aces. Okay. Then team M&J. Team M&J. Okay. RIO achievers. Yes. The optimenters. Okay, that's it. So let's start with the cortical chasers. Next is symbiotes.
Good afternoon. I'm going to take a class on layers of retina on OCT. In the last class, we discussed layers of retina, but I'm still going to give a recap in case you forgot to do it at home. From the vitreous to the scleral side, we have internal limiting membrane, RNFL layer, ganglion cell layer, inner plexiform layer, inner nuclear, outer plexiform, outer nuclear, external limiting membrane, photoreceptor layer, RPE, Brooks membrane, and choroid. Now, in case your face looks like that right now, I've got a mnemonic for you guys. My nerves get in knots outside our easy practice review. You memorize that and you'll be good to go. Now, when you start describing an OCT macula, you have to start with the vitreoretinal interface, inner retina, outer retina, RPE Brooks membrane complex, and then the choroid. Now, you can see that some layers are more brighter than the others. That is because of the different refractive indexes and the amount of backscattering that they do of the infrared rays. You start with the vitreoretinal interface, the vitreous, which is a clear liquid and so it's black, premacular bursa, the clear space above the macula, and the posterior hyaloid, which is visible only in case of PVD. For the inner retina, we have two types of layers, hyperreflective and hyper. It's easy to remember that only the nuclear layers are hyperreflective, and so ganglion cell layer, inner nuclear and outer nuclear. In the outer retina, we have external limiting membrane, ellipsoid zone, which was previously called ISOS junction, interdigitation zone, which is where the OS of the photoreceptors interdigitates with the apical area of the RPE and the RPE Brooks membrane complex. Now, in case you ask your junior for a picture of an OCT macula and he gives you this, now you have no idea whether it's a right or left eye. Well, I'll show you. The RNFL layer is thickest on the nasal side, that is, which has the optic disc. Now, in the first photo, the first photo resembles the fundus photo of the right eye, since the thicker layer is on the right side, so that's the right eye, and similar with the left. Now, in case the backbenchers there were sleeping this whole time, I've got a mid-lecture question for you guys. You don't have to get up, it's fine. All right, what does the blue arrow point to? Wow, the backbenchers answered. Cool, yeah, it is a normal physiological finding, retinal vessel. Now, we come on to pseudo-color and OCT macula. The warm colors shown here, the red or orange, represent increased backscattering, green, moderate backscattering, and black, no backscattering. Now, the lecture part of the afternoon is over. Let's see how much you've retained. Small quiz here for you guys. The first question is, which layer of the retina does the red arrow point to? RNFL, GCL, IPL, or INL? Okay, GCL. Easy question, guys. Come on. How many layers of the retina are hyperreflective in an OCT of macula? The photo won't help you here. 7. Identify the disease shown in the OCT below. Now, there's a bonus question. Let's see if you guys can get it. CNVM, PED, macular hole. Yeah, CMA. Brilliant. Now, the winner here is Pri, but the rest of you guys can catch up in our next class. Now, this is in case you were following the trend bandwagon and you asked ChatGPT for a Ghibli version. Please don't give this to your retina specialist. She'll throw you out of the class. Thank you.
So, do we have the symbiotes here? Okay. So, the next team to be ready is vanquishers. No, they are Amir Aces. Yeah, please be here, na? You are there.
Yeah. Symbiotis. Symbiotis, है ना?
Symbiotes.
Yeah. Retina restaurant serving clarity, one injection per time.
Yeah. Good evening, everyone. Today I'll be giving a brief introduction about the use of ranibizumab in ophthalmology. Imagine the human body as a luxury hotel, and on top of it, we have our exclusive fine dining experience, the Retina restaurants, where we are serving clarity one injection at a time from 2006. This isn't your regular fine dining experience. We do have a special guest, namely neovascular AMD, PDR, diabetic macular edema, retinal vein occlusion, myopic CNVM, and the ROP, which is the youngest diner needing extra care. They all demand only one dish. Tonight's chef special, that is ranibizumab delight, which is served fresh, made with the finest anti-VEGF ingredients. How does it act? It acts by blocking the VEGF receptor, thereby blocking the proliferation, survival, vasodilatation, and the migration of new vessels. How is it cooked? It's simple. We just need 4 ingredients. Our secret ingredient ranibizumab, and a pinch of FDA approval, and the light data from the clinical trials, and a lot of patience. Mix everything sterilely in a kitchen, inject intravitreally, and simmer it for 4 weeks. And come back for results after 4 weeks. This is our ranibizumab delight. Think of this platter as a diseased retina, and each of our guests gets their customized dose of the dish. At table 1, we have our most exclusive dish, the neovascular AMD, which is the first dish to get served by ranibizumab back in 2006, which is always demanding and requires frequent refills. Across the table, we have our sweet tooth diabetic macular edema. Because of excess VEGF, it got macular edema and the causing blurring of vision, where it needs the strongest anti-VEGF to counteract. We do have a silent but a dangerous one, retinal vein occlusion, where one day your vision is fine and the other day you will have sudden painless loss of vision through vitreous hemorrhage. So what happens behind the kitchen? Not all the dishes will make up to the final menu. Yes, I'm talking about the clinical trials. So these trials are like Michelin star judges, and the ranibizumab has to go through a lot of intense scrutiny to make it, to get their FDA approval. So these are the clinical trials. For neovascular AMD, we have Anchor and Marina. So this is the pre-injection picture, and the post-injection it is significantly reduced. And for the retinal vein occlusion, we have Bravo and Cruz. For diabetic macular edema, we have Rise and Ride. This is the pre-injection picture and the post-injection picture. And for the youngest diner, retinopathy of prematurity, we have Rainbow Trial. For those who are wondering this is expensive, let's be honest, fine dining is always expensive. And this Lucentis always comes with the premium price tag. So don't worry, we have our ranibizumab biosimilars, which acts as a budget combo meal with the same effect at lower cost. So for those who don't want to visit our restaurant frequently, from monthly shots to one-time implant, we have the ranibizumab port delivery system, all-you-can-eat buffet, which is the implant surgically placed in the eye and needs refill for every 36 months. Don't think the use of ranibizumab ends there. So beyond retina, we have unexpected guests at our retina restaurants, namely corneal neovascularization, pachychoroid disease spectrum, ocular surface squamous neoplasia, pseudophakic CME, and so on. So let's check in and see what our guests are saying about ranibizumab. These are the reviews. No matter what, ranibizumab has transformed this retina restaurant, whether it's a classic injection or by a budget bio-friendly biosimilars or port delivery system. Our goal is to save vision one injection at a time.
Thank you. Excellent. I think he needs an applause. Two of our judges have missed their lunch today. And you're talking about restaurant. I don't know how much marks they will give it to you. Anyway, all the best.
Thank you.
So do we have the vanquishers who vanquished somewhere and is reappeared? You always vanquish, man. So Amir Aces to be ready, followed by team M&J.
दोनों साइड में नहीं होता पहले हमने तैयारी हमें बोला गया था कि एक रखने हमने ऐसी लैपटॉप लगा दी खाली ना लगे बस तो लैपटॉप लगा दो इसी लैपटॉप में लगा दो दे पेन ड्राइव लगा के कर देंगे वो लोग अच्छा ठीक है मैं इसको भी चालू करवा दूँ हाँ करो ये नेक्स्ट पेन ड्राइव से करेंगे
Yes. Amir Aces, I mean, if you can shift like, if you have pen drives, you can actually connect it and be ready here also. That is also possible. It's not loaded here, but you can use your pen drive on this laptop. Amir Aces, you can use this if you want. Put it and keep it ready so that we can save the time.
Good afternoon. I will be presenting on diplopia charting. So diplopia charting is subjective localization of single point object in patients with complaints of double vision. It is based on haploscopic principle of superimposition. Types of diplopia. On the basis of laterality, diplopia can be monocular or binocular. On the basis of orientation, diplopia can be vertical, horizontal or oblique. Procedure. The patient is explained the procedure and should be comfortably seated with his head erect. In our case, the patient is already well educated and sitting. So he wears red glasses in front of right eye and green glasses in front of left eye. We have to stand behind the patient, and the light source can be a torch or retinoscope at 50 centimeter at the level of patient's eye. Light source can be horizontal if the complaint is of vertical separation of images, and vice versa. It is tested in all 9 positions of gaze. Separation of images can be vertical, horizontal or oblique separation. Cross diplopia and uncrossed diplopia. In isodeviation, the image is on the same side as the squinting eye, whereas in exodeviation, the image is opposite side as the squinting eye. This is a chart showing normal binocular single vision diplopia charting. So to interpret the diplopia charting, step 1 is to see if it's crossed or uncrossed. In uncrossed diplopia, red image is in front of right eye and green image is in front of left eye, whereas it's opposite if it's crossed diplopia. The step 2 is to note the quadrant gaze position with maximum separation of images. Step 3 is to remember the yoke muscle group for each gaze position. Now coming on to the example, this is the first example. This is a case of uncrossed diplopia. We can see red image is in front of right eye and green image is in front of left eye. Maximum separation is in the right gaze. So now coming on to the yoke muscles, it can be right lateral rectus or left medial rectus. So in uncrossed diplopia, there is esotropia and it is right lateral rectus palsy. Example 2, in this case there is uncrossed images, so it is a case of esotropia. Maximum separation we can see is in the levo depression. So which eye is most peripheral in levo depression? It is the right eye. So now coming on to the yoke muscles from this chart, we see left inferior rectus and left superior oblique are ruled out. So it is right superior oblique or right inferior rectus. In case of right esotropia, abductor palsies and obliques abductor. So this is a case of right superior oblique palsy. Now example number 3, uncrossed images and this is a case of crossed images and there is exotropia, and separation of images is seen in all gaze position. So this is a case of third nerve palsy. Uncrossed diplopia is seen in 4th, 6th nerve palsy and crossed diplopia in 3rd nerve palsy. This is a homework which you can solve and come back in next class. Thank you.
This is Vankusher.
Thank you.
Vankusher. You are Vankusher?
क्यों बेटा है?
Like just demonstrate करने के लिए कैसे करते हैं.
हाँ.
चलो कोई बात नहीं. We were not supposed to ask the questions. That's okay.
Right. Next we have Amar Aces.
Ayushman sir.
Vanquisher madam. Yeah. Amar Aces next.
Yes sir.
Okay. 21 sir. Amar Aces.
Sir, Dr. Balla sir, uniform request to the scientific committee member. कुछ दे दीजिए ना.
चाय पानी.
वो मुझे पूछ रहे थे, आई एम डाइवर्टिंग इट टू यू.
आयुष्मान.
Is there an issue? You can set it up. Maybe we can go to the next speaker meanwhile. Team M&J, are you ready? Team M&J. RIO Achievers.
Are there? Team MNJ is there? No.
RIO Achievers. If MNJ is there, you can come and present.
We will miss the chance otherwise.
RIO Achievers.
Ma'am, actually, sir, actually it's in that laptop, but
Sir, दो आगे ना ready करके रखो.
Team M&J.
हाँ, वही.
I think we'll request people to come in front.
The next teams, please be ready. Team M&J, RIO Achievers and Optimenters, if you are here.
Please come in the front row.
Now we have both the podiums that are functional, so the next person can actually... RIO Achievers, yeah, go ahead. 23 RIO Achievers.
Team MNJ is here or no?
No, no.
Marking it absent.
Yeah. RIO Achievers.
Good evening, everyone. My topic for discussion is Bellin-Ambrosio enhanced ectasia map. So as we all know, this is the print of pentacam having 4 quad maps or 4 refractive maps. The first one is the axial or the curvature map. The next one is the anti-elevation map. This is the back elevation map, and this is the corneal thickness or the pachymetric map. This is the Bellin-Ambrosio enhanced ectasia display map or the BAD map. So what was the need for the BAD map? Because it helps the clinician in quickly and effectively screen the patients for ectatic disease. And before going into the details of the BAD maps, we'll learn about the best fit sphere. What is best fit sphere? So the best fit sphere is a reference shape which was used in the pentacam elevation map. It is a computer generated perfect sphere which best approximates the corneal shape in an average, and it takes the average of the corneal curvature map. So if there is a patient of keratoconus, it's also going to take the average of the keratoconic shape of the cornea, and so there is going to be a stemming effect of the best fit sphere, and there is going to be a very less difference between the keratoconic shape and the best fit sphere, so that in such cases we can miss the early ectatic corneas or the early subclinical keratoconus cases. So in Bellin or the BAD maps, we use a new reference shape or the enhanced best fit sphere. In this, what was done that the 4 mm zone around the thinnest location was excluded, and then the new reference shape was formed so that we can get a prominent ectatic corneal shape. So these are the BAD maps. On the one half there are elevation maps, on the other half there is a pachymetric map. There are some parameters like K1, K2, Kmax, pachy apex, and progression index, and ART max, and there are these graphs. So the upper ones are the standard elevation maps, the middle ones are the enhanced or the exclusion maps, and these are the difference maps. This we get after excluding 4 mm zone around the thinnest location. So this is the standard elevation map, and this is the map that we'll get after the enhanced best fit sphere. In normal cornea there is going to be no difference, but in cases of early keratoconus or the ectatic corneas, there is going to be a big difference between both of these. As we can see in the difference map, there are 3 colors: the green, the yellow, and the red color. The green color indicates normal cornea, the yellow color indicates that there is suspicion of ectasia, and the red color indicates that it is a diagnostic of keratoconus. There are 2 graphs in the BAD maps. The first one is the CTSP, that is the corneal thickness spatial profile, and normally it should lie between these 3 dotted lines, and if there is any deviation from this, these are known as they are going to be abnormalities. Like if there is going to be quick flow before 6 mm, or there is S-shaped curve, flapped curve, or inverted curve. And in the bottom of the graph, there are D values or display values. If the display value is less than 1.6 standard deviation, then it means the cornea is normal. Between 1.6 to 2.6, that is suspicious of keratoconus, and more than 2.6 standard deviation means that there is keratoconus. Thank you.
Okay. Thank you. Do we have optimenters team ready? You are ready? No. Optimenters. Kavita's teaching angels. Kavita's teaching angels. Yeah, please. 25, sir. Kavita's teaching.
Optimenters are absent.
Absent. Kavita's teaching.
It's mine. Yeah, this one.
Iconic Crusaders can come in front, please.
Iconic Crusaders. Uh-huh. Iconic Crusaders.
Good evening, ladies and gentlemen. We have a medical emergency in our hands today. There is an unexpected attack in the retinal vasculature. I am your lead investigator, Dr. Ritu Manwani, and our mission is to identify the cause and treat the condition. So let's identify the victim. Our victim is a 65-year-old male patient who is a known case of diabetes mellitus and hypertension. He is a chronic smoker. Let us look at the victim testimony. What does the victim say? So our victim complains of sudden blurring of vision in right eye, which is painless. Let us have a look at the forensic report. How did we solve the case? So look for the RAPD. On fundoscopy, there were diffuse hemorrhages with a classic blood and thunder appearance. On optical coherence tomography, you have to look for the macular edema and prognosticate the patient. On fundus fluorescent angiography, we have to look for the capillary non-perfusion areas and neovascularization. So what exactly went wrong? The crime report. Let us have the closer look at the timeline of events. There is sclerosis of the arterial wall. There is raised intraocular pressure leading to the stasis of the blood, changes in the blood vessel, the hyperviscosity which leads to the blood thrombus formation. So who were the suspects under investigation? Who is responsible for the crime? The risk factors like diabetes mellitus, hypertension, dyslipidemia, obesity, smoking, raised intraocular pressure. So coming to the arrest, how did we stop the criminal? So we have intravitreal anti-VEGF injections, the laser photocoagulation indicated for neovascularization of the iris, neovascularization of angle and elsewhere. We have inflammation fighter, that is corticosteroids, indicated for the patients who do not respond to the normal anti-VEGF agents. The most important thing is the preventing repeat offenders, that is systemic control and lifestyle modification. So it is crucial to have a look at the old case files such as CVOS, Cruz, Copernicus, Galileo to help us solve the case better. Case closed. Is the case really closed? No. We have to watch out for the ferocious miscreants like vitreous hemorrhage, tractional retinal detachment, and the neovascular glaucoma or a 100-day glaucoma. So I would conclude saying that you have to keep patients on a regular follow-up. Thank you.
Iconic Crusaders. This is still not working.
CFS retina is there.
CFS retina, if you are ready, you're next.
Come at the front, please.
CFS retina. Yeah. Trichromats next. Trichromats.
इंस्टीट्यूट का नाम भी
Are you there?
अवेलेबल होना चाहिए.
Trichromats. Are you there?
No. Yeah.
उनका रेडी कर दो इस तरफ ना. CFS retina.
Yes, go ahead.
That's still
Sir,
working.
time.
Presentation, please.
Yeah.
Time.
Go ahead.
Start.
Start. Yeah.
Good evening, everyone. I'm excited to talk about indirect ophthalmoscopy with you, bringing you from basics to brilliance. Let's explore how examining this basic examination can help us go a long way. Here's what we'll be covering today. What is indirect ophthalmoscope? The basics of indirect ophthalmoscope, a step-by-step, common mistakes, and most importantly, resident-friendly tips. Let's meet indirect ophthalmoscope. This is a binocular retinal examination technique which uses a light source and a condensing lens. It usually has a wide field with a stereopic view. The image that is present is a real inverted laterally reversed image. Clinical relevance, it's ideal for peripheral retina where most of the drama usually happens. So this is how a 3D image is formed. First, an aerial image is formed in front of the lens, and then we have a beam splitter where the light is sent to both eyes, and we have the stereopsis, and then we have the IPD adjustment where a single crisp image can be obtained. So how does it actually look? Here's how it looks on the aerial view. Through the lens, it actually looks like this. And then let's move on to the technique of indirect ophthalmoscope. The first important thing would be having a well dilated pupil, and then we have to position the patient well, and it should be a reclined chin up or a chin up position. Then we have to adjust our headset as comfortable as possible, and then we have to hold the 20D lens 4 to 5 centimeters away from the eye. Then ask the patient to look in the opposite direction where you want to see. Align the light, pupil and the lens in the same line. Sweep all quadrants methodically so as to not miss any other quadrants, and if needed, use a scleral depressor. Then here comes the take-home tricks and for the residents. Keep both your eyes open. Use non-dominant hand for lens. Begin at the disc and macula. Anchor hand on brow or cheek. Practice on well-dilated eyes, because when you keep practicing, it is just one step before you achieve perfection. Then the common mistakes that we should be avoiding is having the lens too close or too far so that we'll have a blurred image. Closing one eye can impair stereopsis, misaligning everything, poor patient gaze control, or confusing over inversion. Comparing with direct and indirect, direct is sure, but it has a monocular limited view, but indirect is giving us a wide field stereopsis. And to be frank, if you think retina is your battlefield, indirect would be your aerial drone. If you have not been paying attention, kindly pay attention for the last slide, guys, because this is the take-home message. Always focus on the red reflex so that you can point it, focus your lens. Wiggle or tilt the lens to bring back the image. Your eyelashes and shadows aid into your orientation. Your peripheral vision is your superpower. Thank you very much, guys. If you have any doubts, please follow through. Thank you.
So, Emmer, ACES is ready? Yeah. ACES is ready. Yeah, 21 has come. Yeah. After that, CFS retina. Yeah, CFS retina can come and be ready here. Yeah.
So should I start, class?
Yeah.
I am Dr. Ayushman Singh, and I will be teaching you on keratomalaysia. So first of all, our learning objectives for today. It's not shifting. The learning objectives: what is keratomalaysia, the stages of vitamin A deficiency, the investigations we need to perform, the management, and then I'll be teaching you some frequently asked questions. So keratomalaysia, it is a bilateral ocular condition which is characterized by wrinkling, progressive cloudiness, and increased softening of the cornea due to vitamin A deficiency. Now, as it is a multifactorial disease, so first factor is the poor dietary intake, which leads to vitamin A deficiency, leading to protein energy malnutrition, leading to malabsorption, and thus leading to vitamin A deficiency. It also leads to increase in systemic infections like measles and malaria, thus causing vitamin A deficiency. In the end, as all these factors are causing vitamin A deficiency, it leads to the keratomalaysia, which is our topic. So first of all, it leads to loss of goblet cells, which you all know is a very important factor in our tear film, which leads to decrease in mucus production and thus decrease in our tear film. It leads to release of various destructive proteases, release of various inflammatory cells, and leads to alteration of the mucin genes. All these factors further contribute in keratomalacia. Now, what is vitamin A? It is a fat-soluble vitamin that humans derive primarily from the diet. Now, dietary sources, we all have watched Bugs Bunny, or our favorite cartoon Popeye, or fish liver oil, or egg yolk, or various products like egg or... Now, the various WHO classification. The first stage, which is we are learning from 6th class, is night blindness. We have all watched Golmaal. Then the conjunctival xerosis, the triangular foamy whiteout spots, and in the end, corneal xerosis. If we still don't control it, the vitamin A deficiency causes us dreaded disease, which is keratomalacia, which is the melting away of cornea by liquefactive necrosis. If still not treated, it leads to corneal scarring due to vitamin A deficiency. The last stage, which is xerophthalmic fundus, is characterized by small, white, deep retinal lesions which are scattered throughout the posterior pole. Various blood investigations like serum vitamin A levels, serum retinol binding levels, serum zinc levels are necessary, along with other tests like dark adaptometry. The gold standard, which is the liver biopsy, is rarely performed except in few research purposes. Management is by oral dose, because we all don't want to watch such cute kids cry. Like 0 to 5 months is 50,000 international units, 6 to 11 is 1 lakh, and more than 12 is 2 lakh international units on days 1, 2, and 14. The follow-up is really important for you guys because it comes in NEET PG exam. Some dietary modifications to educate the parents, such as carrots, spinach, and also address the underlying conditions like gastrointestinal issues, malnutrition. It is also important to treat the secondary bacterial infections like antibiotic eye drops and ointments and topical lubricants. In severe cases, the corneal, like keratomalacia, corneal surgery or keratoplasty should be considered. Now, some frequently asked questions. Which of the following food source is the best source of vitamin A? Any answers? We all have had shakarkandi, so we love it. That is the best source among these. Second is, which is the last stage of xerophthalmia which can be completely reversed? It is corneal xerosis. Now, I would like you all to study because I know it has been a long lecture and a lot of you are not paying attention. So please revise it so that I can take a small test in the next class. Thank you.
CFS retina? Yeah. Go ahead. Trichromats, are you there? Trichromats?
A very good evening to one and all. So my topic of discussion is pars plana vitrectomy. So I am supposed to summarize this book in few slides, which is nearly impossible. But so let's just speed back and see how it begins basically. So von Graffe was the first to invade the sacrosanct vitreous in 1863, and it took nearly 100 years for David Kastner to do the open sky technique. After that, 2 years later, Robert McMurray did the first closed vitrectomy. And here you can see he did the eggshell draining and the removal of the white part, which was the first prototype of the closed vitrectomy which we see today. So we have come from eggshell to conventional, now heads of vitrectomy. So things which were inaccessible in the past, so these were the patients, real patients, so where no eye drops or systemic medication will be very effective. So these are doomed cases. So now the pars plana vitrectomy is now the source of the revival of these cases. So why pars plana? So pars plana is a flat, relatively avascular, doesn't have a sensory function, and it has no involvement in producing aqueous or vitreous humor. So, and what is the vitrectomy? So now you can see we did the closed vitrectomy. That is the 3-port vitrectomy is now being done. With each port is dedicated to for some specific function, with the infusion cannula for the maintaining of IOP and the vitreous cutter. And in the second video, you can see the vitreous is actually cutting by the vitrectomy cutter. So, which were inaccessible in the past, these all eyes who were doomed now can achieve the various, you can say, can see things. The patients are very happy. So, we can say there are still very things you can see the how is the vitrectomy machine, how you can see how you can see the posterior pole. There are various cutters, there are various methods to do. So it's your cue to proceed further and see how and just go and read the pars plana vitrectomy, which is a very interesting topic. And just that is, thank you very much.
Trichromats, Kaveri,
CFS retina.
CFS हो गया sir. Kaveri, Marvel you can come. Site seekers, you can be ready next. Kaveri is absent sir. Yeah, Marvel is present. She is doing Marvel. Yeah, site seekers can be here next. Yeah.
You are Kaveri?
This is Marvel, right?
इस बार 2 बार आपने मुझे कोई कह रहा था सुपरवाइजर बन जाओ, रिटायर होना था। मैंने मुझे नहीं बनना तुम्हारी थीसिस में, कुछ भी नहीं था उसके अंदर। एंटीरियर सेगमेंट ओसीटी फाइंडिंग इन एंगुलर क्लोजर एंड क्लोज एंगल, कि वो रिटायर होने वाले थे तो मैं था इजी टॉपिक दे दिया। तो मैंने कहा मुझे नहीं बनना इसका सुपरवाइजर, इवन इफ इट एड्स टू माय
Marvel. Yeah.
दैट्स व्हाई उसने कहा होगा मेरा नाम मत डालना।
Yeah. Start. You can go.
Good evening, everyone. Today's class will be on one of the most important glaucoma surgeries, trabeculectomy. So as you all might have guessed, the aim of the surgery is to reduce intraocular pressure. So this is done by creating an alternate pathway for the aqueous drainage. So basically we create a fistula from the anterior chamber to the subtenon space so that aqueous can drain directly to the subtenon space, forming a filtering bleb. Now when to do it? It is done when glaucoma is not controlled on maximal medical therapy, when you have a very non-compliant patient, and when there is disease progression despite of good IOP control, and when the IOP is too high, causing worsening of disc damage. Now one important concept which makes TRAP different from other surgeries is that here we do not want the episcleral and scleral tissue to heal completely. So there are many precautions taken by the surgeon to prevent healing of episcleral tissue. So whenever you see this particular symbol in any one of the upcoming slides, just remember that it is one such precaution taken by the surgeon. Now coming to the pre-op preparation, almost all the AGMs, including PG analogs and beta blockers, are stopped 2 weeks prior to the surgery, and the patient is started on topical corticosteroid. Adrenaline and anesthesia may compromise ONH circulation, so try to avoid giving repeat blocks. Pre-op mannitol is a must to prevent snuff-out phenomenon. Now coming to the proper steps of the surgery, it can be done under subtenons or peribulbar or retrobulbar anesthesia. Now I'll take you in a step-by-step manner. The first step is corneal traction suture. So this will give a good exposure to the field of surgery. The second step is conjunctival dissection. So this can be done in a fornix-based or a limbal-based manner. The video which is playing here is showing a fornix-based conjunctival dissection, which is also one of the most preferable way of conjunctival dissection. The third step is antimetabolite application. So the most commonly used antimetabolite is mitomycin C. It can be either applied with the help of sponges, or you can also inject it into the subtenon space. One precaution to be taken is that never touch the cut edges of conjunctiva to the sponges. The fourth step is scleral flap formation. It can either be a triangular or a rectangular flap, and the depth should be half to 2/3 of sclera. Next is sclerostomy. So we use a Kelly sponge to cut a block of tissue containing trabecular meshwork. The sixth step is peripheral iridectomy. Why is this done? This is done to prevent iris incarceration into the sclerostomy opening. So it will prevent pupillary block in the future. The last step is closure. So this sclera as well as conjunctiva have to be closed separately. So we can either use a fixed suture or releasable sutures for scleral closure. The advantage of releasable suture is it will prevent post-op hypotony, and it can also be released once the AC is stabilized. This is a picture which every surgeon dreams to see after the surgery. This is an ideal bleb. So it should be avascular, there should be numerous microcysts, and it should be low to moderate in height and diffuse. Coming to post-op care, the patient is started on steroids, cycloplegics and antibiotics. One of the most important complication which you might encounter is a post-op shallow AC. So once this happens, look for the IOP whether it is high or low. If it is high, it might be a pupillary block, suprachoroidal hemorrhage or a malignant glaucoma. If it is low, it may be a bleb leak, overfiltration or choroidal effusion. These are some of the other complications which will be discussed later in the upcoming classes. Thank you.
Sir, marvel. Sight seekers. Next, do we have Southern Stallions? You can be ready here.
Your sight seekers?
This is sight seekers.
Matthew Shaji. What? Matthew Shaji.
Go ahead. Yeah, go ahead.
Good evening, everyone. Our topic for today is pan-retinal photocoagulation. Before getting into the topic, let's imagine a 40-year-old diabetic male comes to your clinic with 6/6 vision, but with his fundus shows proliferative diabetic retinopathy. Will you treat now or wait? Let's get into the topic. PRP is the mainstay treatment in diffuse retinal ischemia, classically in proliferative diabetic retinopathy. What is PRP? It is a scattered photocoagulation. As the name tells, it's a laser treatment that involves applying scattered burns to the hypoxic retina to reduce retinal ischemia and neovascularization. The indications are most commonly PDR, followed by central retinal vein occlusion and ocular ischemic syndrome. What is photocoagulation? By increasing the tissue temperature by 20 to 30 degrees Celsius, it causes photothermal reaction, protein denaturation, coagulation necrosis. It is a pigment-dependent process. The most commonly used laser with photocoagulation effect is frequency double Nd:ARC laser. What are the proposed theories? The injured RPE cells causes more oxygen available to the inner retina and vitreous, which leads to decreased stimulus for the neovascularization. By this process, the PRP converts hypoxia to anoxia. The prerequisites are physician fitness in case of diabetic nephropathy, an informed consent, a well-dilated pupil, a local or topical anesthesia. The laser treatment can be delivered through slit lamp technique or laser indirect ophthalmoscope. The LIO is indicated in hazy media like cataract, in retinopathy of prematurity stage 3, in postoperative patients, and in old age patients or who cannot sit for a longer duration. The most commonly used contact lens is Mainstar PRP 165 for its laser spot magnification of 2 with field of view 165 to 180 degree as the name goes. The parameters are spot size of 200 to 500 microns, power of 140 to 250 milliwatts, duration of 200 to 500 milliseconds. It should be of 1 burn width apart. For complete treatment of PRP, 1800 to 2200 burns are required. According to the Core retinal burn intensity classification, the PRP laser mark should be of moderate intensity. During laser procedure, start temporally just outside the vascular arcades, 2 disc diameter temporal to the fovea. In nasal side, begin about 1 disc diameter nasal to the optic disc. If vitreous hemorrhage occurs, it would be difficult to laser inferior retina. So the inferior half of retina is treated in the first session. Let's see the complications. The most common is loss of peripheral visual field. In single session PRP, macular edema, secondary angle closure can happen. Iatrogenic causes like accidental burns to the adjacent structures can happen, most importantly foveal burn. And it can also be associated with contraction of fibrovascular tissue and tractional RD. In recent advances, pattern scan laser, it is a multi-spot photocoagulation system which delivers rapid laser burns in a predefined pattern in 10 to 30 milliseconds. The other recent advances are subthreshold micropulse laser, image-guided laser like Navilas, targeted PRP for capillary non-perfusion area, which usually show for retinal vasculitis, in telemedicine and remote laser planning with AI-based imaging. In future, we can expect nanosecond laser, femtosecond laser. I like to conclude that PRP is not just about burning the retina, it's about preserving the light of sight in a sea of ischemia. Thank you.
Good. Next, Southern Stallions. Do we have ocular luminaries? Yeah, you can be ready in the next podium. Thank you. Southern Stallions, can you start the presentation? Yeah.
Hello. Good afternoon all. My topic for today is abducens nerve palsy. First, I would like to introduce my friend, Alfred, who will be helping me with the demonstrations. Abducens nerve is mainly responsible for the lateral rectus muscle. It is also responsible for the coordinated lateral movement of both the eyes. Here you can see Alfred is looking to his left as well as to his right. Now have a look at Alfred. You can see right eye esotropia in primary gaze. This is a classic finding you see in abducens nerve palsy. Also, Alfred has developed horizontal diplopia. Let's see what he does to correct this diplopia. Yes, he has turned his head to the right side. So now let's go to the anatomy and the course of the nerve so that we can find where the lesion is. First, we have the nucleus part. The abducens nucleus lies in the dorsal pons in front of the fourth ventricle, lateral to the median longitudinal fasciculus. The facial nerve forms a loop around the abducens nucleus, forming the facial colliculus. Isolated sixth nerve palsy can never be of nucleus origin. Next, we have the fascicular portion. It is basically between the pons and the pontomedullary junction. We have a lot of syndromes over here, mainly the Millard-Gobler, the Raymond, as well as the Fovile syndromes. Now we go to the intracranial portion. The nerve, after exiting the pontomedullary junction, enters the subarachnoid space, goes forwards, upwards, over the clivus, then makes a sharp turn and enters the Dorellos canal. Here you get the false localizing sign which happens due to raised intracranial pressure. This causes the brainstem to go downwards and stretching the nerve. Next, the nerve enters the body of the cavernous sinus. Here, it is in close proximity to cranial nerve 3, 4 and 5 and you get a lot of symptoms similar to cavernous sinus syndrome. The nerve now enters the orbit through the superior orbital fissure. Here again, the nerve is in close proximity to cranial nerve 3, 4 and 5 and you get symptoms similar to superior orbital fissure syndrome. I have a homework for you to differentiate between superior orbital fissure syndrome and the orbital apex syndrome. The nerve now terminates by supplying the lateral rectus. Now let's go to the examination part. Age is the most important factor. If patient is less than 50 years of age, you have to do a neurological examination. Ask for the characteristics of the diplopia, the associated symptoms, trauma, systemic disease. All this will give you an idea of where the lesion can be. Do a complete CNS examination. For vision assessment, do a full squint evaluation, including diplopia, Hess charting, force duction and force generation test. In the Hess chart which I have provided below, you can see a restriction of the right lateral rectus. Other investigations include MRI, CT, blood and CSF analysis. Treatment, you have to treat the cause. For diplopia, you can see Alfred is using the Fresnel glasses as well as the ocular patch. Botulinum toxin injections can be given to the medial rectus muscles. Surgery, we usually think about it only after 6 months. If you're having a partial paralysis, you do a resection of the horizontal muscles. Whereas if you have a complete paralysis, you do a vertical rectus muscle transposition. These are the various differentials. I hope all of you are smiling like Alfred after my class. Thank you.
Yeah. Atira, Dr. Atira is there. Team UCMS, you can be next. Get ready here.
Hello, mic check. Am I audible?
Yeah.
Yes, class. Good afternoon, everyone. So the topic for today is pneumatic retinopexy, the bubble to the rescue. So quiz time. Do you know what is pneumatic retinopexy? Yes. Fluid tamponade of the retinal tear, artificial prosthetic tamponade, gas tamponade, or only postural modification? Can you guess, guys? Yes. Okay, so it is C, the gas tamponade of the retinal tear. So introducing, it is the injection of the expansile gas into the vitreous cavity followed by cryopexy or laser photocoagulation. As you can see, there is a superior tear which is leading to the retinal detachment. So what happens
Go near
is,
the mic. Yeah.
so what happens is that the vitreous moves inside the tear and leads to subretinal fluid accumulation, which leads to detachment. What we do with this air bubble is that it tamponates the tear and it prevents the further egress of the vitreous fluid into the subretinal space, and the existing fluid is absorbed by the RPE, leading to settling of the retina. So the indications are rhegmatogenous retinal detachment due to a single or multiple breaks less than 1 clock hour, superior breaks, clear media to allow cryopexy, PVR not more than grade B, and cooperative patients. So recently there has been a study which expands the indication to include inferior fundus as well, but the prognostication is poor. So pre-procedural examination, we have to do a thorough slit lamp evaluation to look for conjunctival integrity, corneal clarity, anterior segment depth, angle closure status and lens status, especially the aphakia and pseudophakia, because due to vitreous strands, these cases may pose challenges. Intraocular pressure. Posterior segments warrant adequate evaluation to look for number and size of the breaks and their position. So the procedure is, first of all, we give the local anesthesia and then we control the intraocular pressure by giving the anterior chamber paracentesis by a 30 gauge needle. Then the gas injection is basically in the inferior temporal quadrant. As you can see, first it is demonstrated that there is a formation of a tear and the RD. Now the surgeon will go through the pars plana route, that is 4 mm from the limbus, because this is phakic eye, and inject the air bubble, which not only tamponates but also supports the RD, leading to absorption of the retinal fluid and the post-op postural modification. Now this is also demonstrated in the photograph as shown. So there are multiple gases which are used for this procedure and their properties are displayed in the table: air, SF6 and C3F8. So post-procedural care is important and we have to assess the size and adequacy of the bubble. For the control of IOP is very important. We have to adequately check by the optic nerve head perfusion, and post-injection positioning as indicated in this Toronto technique is also very important. So we follow it by laser retinopexy. So these are some precautions जो कि हम patients को देते हैं, that do not lie on back for prolonged periods to prevent cataract formation, avoid air travel and avoid scuba diving. So outcomes are very good, and recently it has been indicated that up to 60% of the anatomical reattachment rate can be found out. So guys, sleeping guys, can you guess what is it? Yes, these are the fish eggs. This is one of the complications of the pneumatic retinopexy due to faulty injection, and it will spontaneously resolve in 24 hours. Another one is gas entrapment in the canal of Pettit, and other complications are subretinal gas, which can be maneuvered if the break is large, and raised IOP, CRAO, etc. So it is a valuable, cost-effective, minimally invasive technique, and it is a compelling alternative to more invasive procedures. Thank you.
Next we have team UCMS. Is the site seekers are there? Site seekers, you can be ready next. Yeah,
Okay.
UCMS can go ahead.
Good evening, class. Today we are going to discuss about ocular
UCMS.
myasthenia. So, I will tell you a
Atira
story. One day I was sitting in the OPD and a patient came to me. She started saying that she has right eye drooping, and she was saying two things. Well, and then I said, don't you worry, you have came to the right place, let me examine you. So, what do you mean by ocular myasthenia? It is an autoimmune disease in which antibodies destroy the neuromuscular connections, resulting in muscle weakness and fatigability. So, smaller muscles are affected first, and 85% of the myasthenia gravis patients presents first with the ocular signs and symptoms. So, to understand that, we have to understand the pathophysiology of myasthenia gravis. This is a neuromuscular junction showing the presynaptic neuron, which is activated by the calcium and sodium gated channels, which causes the release of acetylcholine into the neuromuscular junction, causing the action potential of the postganglionic muscle fibers. So this is a normal neuromuscular junction in the left, and in the right side you can see the destroyed postganglionic membrane. So myasthenia gravis be like receptor tod salega. Then on examination you can see the right eye ptosis, which is increased on sustained upgaze, and there is mild MR restriction on adduction. MR be like मैं तो थक गई भाई साहब. Then there is Kogan lead twitch sign, which is elicited by asking the patient to look down for 10 to 15 seconds and then ask the patient to do a vertical saccade back to primary position. What happens? The ptotic eyelid overshoots the primary position and comes back to the primary position. Now, enhancement of ptosis is another sign that you can elicit in a patient. What we do, we by manually elevate the one eyelid of the patient, which causes the increase in the ptosis in the other eye. Why it happens? Because it causes decrease in the effort needed to open the eyelid, ipsilaterally, thus resulting in relaxation of the contralateral levator muscles. Then the patient asked me, so what do you think, doc? And I tell her, just let me conduct few tests and I'll tell you. So I give her a ice pack. I ask her to keep the ice pack on her eyelids for 3 to 5 minutes, and I observe, is there any improvement in the ptosis? ideally, after this test, if the improvement in ptosis is by more than 2 mm, we can consider it positive. So now another test that we do is hydrophonium tensilon test. In this test, we give the patient hydrophonium chloride, and we see if there is an elevation of islets or present or not. Now we can also test the patients for the antibodies by performing the serology. So there are 3 different types of antibodies that we can check on a patient: serum anti-acetylcholine receptor antibody, anti-MuSK antibody, anti-LRPA4, anti-agrin antibody titers. Now 50% of the patient are positive, 50% are negative. So what about those patients who are seronegative? We have to go and confirm it by electromyography. So this is a test in which we repeatedly stimulate the nerve and we measure the decline in the compound muscle action potential. We can also go for the mediastinal imaging. 10% of the patients have thymoma. So the management includes, we can give the patient pyridostigmine, or we can start immunosuppressive therapy, or we can go for the thymectomy. Thank you.
Yeah.
So this is the Ghibli image. Thank you.
If you have team SVMC Tirupati ready, you can be here next. So site seekers can go ahead. Yeah.
A very pleasant evening to my wonderful class. So we'll be trying to grab some important points about gene therapy in retinal disorders. So retina, as we all know, is a highly specialized neural tissue and its integrity is gene dependent. So genes don't just shape its development, they maintain its architecture, regulate function and ensure cellular homeostasis. So a single mutation can disrupt these finely tuned processes, leading to retinal degeneration and hence irreversible vision loss. So as per literature, over 2 million people worldwide are suffering from gene-related retinal diseases, either inherited or acquired, and over 270 genes have been identified which are found to be responsible for these conditions. A quick overview of Walt's visual cycle. So why this is important? Because it involves some important enzymatic reactions which are linked to several retinal diseases. A few of them are depicted here. So RPE65 is an example of very important gene in this cascade, and cells with defective RPE65, they lead to recessive blinding disorders like Leber congenital amaurosis. So this table here is showing retinal diseases caused by specific gene mutations, and you can see that more than one gene is involved in most of the diseases, and knowing these genes obviously helps us in developing gene therapy. And the potential target cells are photoreceptors and RPE cells, mainly RPE cells, because this has single layer and hence it is preferred. So gene therapy works via gene augmentation, gene editing and gene silencing. In augmentation, a normal copy of gene produces a protein that makes up for the functional loss. Gene editing and silencing, they are preferred in autosomal dominant conditions. Gene editing is done via a very newer modality CRISPR, that is clustered regularly interspaced short palindromic repeats. So CRISPR and CRISPR associated proteins, they are used for very precise editing, either by introducing, modifying or deleting specific genomic sequences. So both viral and non-viral vectors have been tried, and among these vectors, adeno-associated viruses are the most promising in gene therapeutics, and the commonest mode of delivery is subretinal space, because this potential space gives the injected material a direct access to the plasma membrane of RPE and photoreceptors. Now imagine a world where blindness from a genetic mutation could be reversed with a single treatment. So for patients with RPE65 mediated retinal dystrophy, Luxturna made that a reality. But it was not just a breakthrough, it also paved the way for research in ARMD, neovascular and inflammatory retinal diseases. No doubt, it was a ray of hope, but everything comes with a cost. So despite its excellent potential, it faced significant hurdle, including its exorbitant price tag. And a major disadvantage is that advanced retinal dystrophy and degeneration, they are irreversible. So at the time of initiation of therapy, there should be good visual acuity and there should be viable neuronal tissue so that it works properly. As for now, there is no approved treatment in our nation, but I'm very sure soon there will be one because of the ongoing research in some of the very good centers of our country. So talking about the future of gene therapy, it's not about scientific breakthroughs, it's about making it accessible, affordable and impactful, and obviously we need government support for that. So this is a real world story. He is Corey Haas. He was born with a genetic disorder, Leber congenital amaurosis, which stole his sight when he was 8 years old. But one breakthrough changed everything, and that was gene therapy. Thank you.
Yeah. Next is SVMC Tirupati is presenting now. Do we have NN edutainers? NN edutainers, NeuroNexus. You can be here next. Yeah. Tirupati can go ahead, SVMC. Yeah.
Good afternoon, everyone. I am Dr. Lakshmi Sharma. We'll be teaching you today corneal lacerations repair. And by the end of the session, my students will be able to know what the goals of repair are, its management, followed by principles of corneal suturing and its complications. Before we dive into the details, we must first understand what it is and how frequently it occurs. So corneal laceration is any injury that involves or disrupts the Bowman's layer and may involve stroma in the deeper layers. And studies have shown that it accounts for 59% of all ocular lacerations. So while repairing a corneal laceration, our aim is not just to close the wound, but to restore its natural shape and function and minimize post-op scarring and astigmatism. So we'll start the management with evaluating the condition with the appropriately taken history and slit lamp examination. And one of the most important tasks while dealing with the full thickness wound is to rule out or confirm any intraocular foreign body or any intraocular pathology. So all corneal lacerations are different, so treatment must also be different for each wound type. For example, in partial thickness, we'll debride the wound first, followed by Seidel stitch to rule out any full thickness wound, and we'll apply bandage contact lens to help it heal. In full thickness, where size is less than 2 mm, we'll apply tissue glues, amniotic membrane, and bandage contact lens to seal the wound. And whereas if size is more than 2 mm, it usually requires suturing, that too in the operating room. So let's break down some key principles for the corneal suturing, where a typical monofilament 10-0 nylon suture with the fine spatula needle is used, through which shorter and shallower bites used centrally, whereas longer and larger bites used peripherally. And if at all possible, we need to avoid suture bites to the visual axis, and it should be symmetric on each side of the wound. And it should include 80 to 90% of the stromal depth and should be tightened enough to avoid any leaky wound. For depth, slip nodes are preferred, where one end is pulled vertically and other end is pulled horizontally. These all nodes are trimmed short and superficially buried in the stroma, that too away from the visual axis. And if we see here, it includes the 80 to 90% of stromal depth. Shallow bites result in internal wound gaping, and full thickness bites result in microbial invasion. Unequal depth or unequal height will result in the wound override. Now we'll revise some scenarios where in oblique laceration we need the equidistant from the posterior aspect. Remember posterior aspect of the wound, and avoid any tension over the shallower side of the wound while tying the suture. In case of linear laceration, we'll start suturing from the center and then the subsequent halves. Remember here green means the first suture, blue means the subsequent sutures. In case of gaping laceration, we'll start from the end and then zip it up. In case of angle laceration, we'll start from the apex and then the linear lacerations. While talking about ciliate laceration, which is quite challenging, we'll apply a pursing suture to approximate the apices of the wound, as we can see here, and then interruptive sutures to close the remaining aspect of laceration. In case of corneal laceration, we'll start from the limbus and then the corneal aspect followed by the scleral aspect. In case of tissue loss, we need to apply a patch graft to create a watertight closure. So even with precise suturing, complications like these can arise. For example, from endophthalmitis, which is the most dreaded complication, to the sympathetic ophthalmia, which is quite rare. Now let's recap some key takeaways. We state that corneal lacerations can present with various depth, shapes and sizes, and prompt treatment and management followed principles can reduce the post-op complications. These are the sources that guided my presentation, and thank you for your kind attention.
Do we have sight savers? You can be ready next. NeuroNexus. Your NeuroNexus, right? Yeah, you can go ahead.
Good evening, class. Can we really see all 360 degrees? Answer is no. Because of our facial symmetry and the anatomy of the eye, temporally we can see about 100 degrees, superiorly and nasally about 60 degrees, and inferiorly about 75 degrees. So now you might think that whatever machines we have can actually map the entire visual field, but that's not true. Actually, only Goldman perimetry can map the entire visual field. So let's talk about the Goldman visual field. So this is the normal hill of the vision, where visual field is the island of vision in the sea of darkness. So how to assess the visual fields? We can do it by confrontation, Amsler gate, Zerum screen, Goldman kinetic perimetry, HFA static perimetry. So Dr. Goldman Hans was the first person who coined the first model of the Goldman, And so basically it is a hemispherical bowl with the background luminescence of 31.5 apostle bills, radius of bowl being 30 centimeters, and we have different sizes of the stimuli available ranging from size 0 to 5. And also we have different sizes of the luminescence denoted as alphabets and numbers. So now how it actually works, first of all I need to explain the procedure to the patient, give the good refractive correction, patch the another eye, and then we have to start the procedure. We have to ask the patient to look at the central target, then slowly I'll move the target from periphery towards the center. As soon as the patient sees the target and presses the buzzer, I need to mark that point manually. So this entire procedure has to be done throughout the 360 degrees, and finally I'll get the final map. So let's look at how it looks. So this is the final interpretation. Careful guys here, whatever we are seeing area is whatever the drawn areas is the seeing areas in contrast to the HFA. So now let's have some rapid fire questions. So this lady came into the OPD with the transient blurring of the vision and frequent complaints of the headache. And on fundus examination, she had bilateral disc edema. And when we did the field, she had enlargement of the blind spot. And on imaging, it came out to be a thickening of the optic nerve sheath. So what is the answer? So this is the papilledema. Next question, a patient entered in our OPD with the complaints of frequent problems while driving. So when we did the imaging, when we did the field, we got bitemporal hemianopia, and when we did the imaging, there was a mass in the sella turcica. So this is suggestive of the pituitary adenoma. Next patient came in our OPD with the complaints of transient blurring of the vision on fundus. Right eye had slight disc edema, and when we did the field, it came out to be inferior altitudinal defect suggestive of NAION. So this patient came with a very bizarre defect in the temporal field, and when we did the fields, it came out to be temporal crescent field. And when we did the imaging, it came out to be occipitoparietal sulcus lesion. So what is the relevance of Goldman in this era? It is customizable, can be done for the low vision patients, and human interactions there. So it's good for patients who has cognitive and physical limitations, and also we can rehabilitate the patients of advanced RP. But yes, it is time consuming, operator dependent, limited sensitivity for the central fields, difficult to quantify the progression, and limited standard protocols. So this is a model of Octopus 900 which combines both HFA and Goldman. So here I'll end my slides with this quote.
Sight savers is ready next. Yeah. Sight savants. Do you have sight savants? Do you have ESI, PGI, MSR, New Delhi? You can be ready next. Yeah. Sight savers can go ahead. Yeah.
A very warm good evening, class. Today we will learn about confocal microscopy. Before we move on, you can scan this QR code for the pre-session test. Thank you for the very fast response. We will move on to the session. Confocal microscopy is a non-invasive technique of imaging the live human cornea under high magnification. By the end of the session, you will like to know all this about confocal microscope. This is about the evolution of confocal microscope. Coming to the principle, the laser light source falls on the dichroic mirror. From the mirror, it falls on the specimen. From the specimen, the light is reflected to the detector. The illumination source and the detection source lies in the same focal plane, and hence the name confocal. There are different types: tandem scanning, slit scanning, and the current gold standard is laser scanning confocal microscope. This is how we use a laser scanning confocal microscope. You can see a disposable tomo cap. It will applanate to the patient's cornea, and there is the observational camera. It will let you know to what extent the patient's cornea is applanated. So students, it's very important to know how a normal cornea will look under confocal microscope. Here, the upper four images are those of epithelium. Here, the cell bodies are hyporeflective and cell borders are hyperreflective. Beneath that, we have subepithelial nerve plexus. Here you can see hyperreflective linear strands. Beneath that, in anterior stroma, you can see oval-shaped hyperreflective keratocytes. Beneath that, in posterior stroma, the number of keratocytes are lesser, and beneath that, you can see hexagonal cells in the endothelium. In endothelium, the cell bodies are hyperreflective and cell borders are hyporeflective. So students, what are the indications of confocal microscope? In acanthamoeba keratitis, you can identify the cyst by its double-walled appearance, bright spot or signet rings. In nocardia keratitis, you can see thin filament with beaded appearance. In microsporidial keratitis, if it is epithelial, you can see the characteristic rosette formation, and if it is stromal, you can see linearly aligned hyper-reflective dots. In fungal keratitis, the fungal hyphae can be identified by the multiple interlocking wide lines. Confocal microscopy is very useful in corneal nerve assessment. You can look for nerve length and density, and is very useful in neuropathies. In post-refractive surgeries, you can look for epithelial thickness, flap thickness, interface haze, etc. In limbal stem cell deficiency, you can look for the functionality of the limbal niche. In corneal graft surgeries, it will distinguish between the corneal edema due to corneal graft rejection and endothelial decompensation. Students, what are the advantages? It's a non-invasive technique, you can have a rapid examination, you can have a higher resolution, and it's an emerging tool for the diagnosis of infectious keratitis. So what are the limitations? It requires a high level of expertise, it requires patient cooperation, and if there is a dense corneal infiltrate, it will obscure the view, and it is very expensive. Students, now you can scan the QR code for the post-session test. Here I can see that most of you have scored 100% score. Thank you.
Yeah. ESI PGMS, sir. Do we have lens legends? Lens legends. You can be ready next.
Hello.
Yeah, go ahead.
A very good evening to all the budding ophthalmologists present here. I hope you all are doing your cataract surgeries well. So just imagine that, that you are doing a routine cataract case. Everything is going very smooth. But suddenly you encounter that there is a sudden deepening of the anterior chamber and a pupillary snap. So what it is? Yes, a PCR has occurred. So do you think PCR is a disaster? No, it is just a test of your surgical skill and composure. Every cataract surgeon at one or the other point of time will encounter a PCR. So it's just that you have to be decisive in that, right? So when do you think a PCR can occur? There are some cataracts like posterior polar cataract, traumatic cataract, post-vitrectomy cataract which are prone to PCR. But PCR can occur in any kind of cataract surgery. So, and also it can occur at any step. Suppose you are doing a capsulorhexis and it extends beyond the equator, or you are doing a hydrodissection but you don't decompress the nucleus. It can happen. Doing phacoemulsification or doing irrigation and aspiration, if your probe touches the posterior capsule, it can happen. Even at the last step, while you are dialing the IOL, it can happen. Right. So, why do you think posterior capsule is so important? Because it basically is a barrier between the anterior segment and the posterior segment. So, if it ruptures, what can happen? The nuclear pieces, they can fall behind, and the vitreous, it tends to come forward. So, if PCR occurs, how will you manage it? First, you have to recognize it. There may be a sudden deepening of the anterior chamber, or the nucleus, it may seem to be tilted, like, or in an altered plane, or initially which was the nucleus which was rotating, now it is not rotating. If these scenarios happen, you have to suspect PCR. Now you know the PCR has happened. So what is your first knee-jerk reflex? You will try to take the phaco probe out. But no, you don't have to do that. Just keep the probe there. Stay in the position 1 and inject the OBDs. Once you inject the OBDs will try to tamponate the PCR and it will prevent the vitreous prolapse, right? Also, it will stabilize the lens material. So once you have done this, now what you will do next? Next, you have to remove the nuclear pieces. So you have to assess whether the nucleus is soft or a small amount of residual nucleus is there. You can easily remove it by phaco, but you have to lower the phaco parameters. Later, if you see that the nucleus is significant, large amount, so you have to convert to non-phaco techniques such as SICS or ECC. So once you have removed the nucleus, so the nucleus is out. Now what is there? The vitreous. You can see the vitreous is coming out. So what you will do? You will do vitrectomy. So during vitrectomy, you have to remember that the cutting rate should be the highest and the vacuum should be the lowest. So, and when you are putting the vitrectomy probe, just keep it there. Don't try to pull it while cutting. Otherwise, it can cause retinal tears. Vitrectomy done. Cortex removal you can do how? Just by doing either with a vitrectomy cutter or with a bimanual irrigation aspiration cannula, you can do the cortex removal. Also, there is a dry technique where you just inject the OVDs. So, cortex done, right? Nucleus out, vitrectomy sorted, and how will you stain the vitreous? You can use triamcinolone for staining, right? Next, so everything is now, we have the most critical step of placing the IOL, right? So you have to assess the capsulozonular support. If it is good enough, then you can place the IOL in sulcus. Which IOL? 3-piece IOL. And if it is not there,
Right.
then you can leave it aphakia and go for secondary IOL.
Yeah.
Thank you.
Okay. Lens legends. Do we have retiglow? Retiglow. You can be ready. Next. No. This is 42. PG IMSR New Delhi has presented. Now it is 43 lens legends.
44.
Yeah.
44 lens
Yeah.
legends.
Savants. Yeah. Now lens legends. You can go ahead. Yeah.
Nowadays, we know that we can achieve spectacle independence, but the real challenge is in presbyopia patients to achieve the stable and good near and intermediate vision. So here we have a multifocal IOL where by definition they divide the light energy that is entering into the eye and distributes the light energy into different foci. So inception of this thought has emerged when in late 1980s when Dr. Hoffer observed a patient with a decentered IOL who is still able to read a 6x6 even with or without aphakic correction. So it dawned to him that it was actually the pupil is like a bifocal lens and the patient is able to read even without aphakic correction. So and the brain is actually suppressing the hyperopic blurred image and only accepting the clearer image the patient wanted to see. And this is the first model of a bifocal IOL. And John Pierce was the first to implant the bullseye type of multifocal IOL, and Array is the first FDA approved IOL. So basically, based on the optical principles they utilize, we have 3 different types of multifocal IOL: refractive, diffractive, and a combination of both. So I'll take each one separately. Now, refractive IOLs is also known as a bullseye design. In this, we have 2 types. And the first one is 2-zone lens type. In this lens, we have a center for the near vision, center for the distance, center for the near vision, and the periphery surrounded for the distance. The major disadvantage with this type of IOL is that when the pupil constricts in the bright light, the patient had poor distance vision. So it became imperative that the center part should function for both distance and near. And there we have got the annulus type of IOL. In this, the center, it has both for distance and near. So what are the major limitations with refractive type is they are pupil dependent, and slight off axis or deviation can cause aberrations, and they have high intolerance to kappa angle, and they have severe photic phenomena like glare, halos, and starburst. And what is kappa angle? Kappa angle is nothing but angle at the entrance of the pupil between the line of sight and the pupillary axis. Because it is important for these IOLs to be in the center, it should not be more than 0.5 mm. So second type is diffractive type of IOL. We know that when the light hits a narrow aperture or a sharp object, it propagates forwards as waves. And when these 2 or more waves combine, they produce an interference pattern. And this interference pattern will give a desired foci at the distance. So how a diffractive IOL is constructed? We have a diffractive element on a monofocal optic to produce a diffractive optic IOL. So this is based on wavefront optics, and we have a kinoform base. What it is a repetitive variation of lens thickness, and which allow the selective delay in the incoming light rays, so that a constructive interference is produced at a desired distance. So the height of the IOL, the height of the diffractive ridge, it determines the amount of light energy that enters, and whenever the light energy is half the wavelength of the light, it divides the light energy into 0 order, first and second. 0 order is the light goes undeviated, which is 40% for the distance, and 40% for the near, and 4% is second order, which is not used in the bifocal IOL. So the width determines the amount of vergence, that is near ad. The larger, the lesser is the ad.
Okay.
So apodization is the concept of gradual decrease in the height, which allows to use the distribute the light energy equally. And trifocal is where 2 bifocal kinoform base elements are added.
So EDOF is nothing but it doesn't provide a single focal point, but it produces an elongated focus. Okay, sir. Thank you. Let's stop it.
Do we have off the oracles? Off the oracles. Rods and cones. Rods and cones. Spectacular. Spectacular can be ready next. Yeah. Now this is retiglow. Lens legends is over. Now retiglow is presenting. Yeah. Go ahead.
Good evening everyone. Before going to the topic, these are the chocolates which will be given at the end of the session. So all kindly pay attention. Now my topic is orbitotomy. Before going that, we have to know a view about the surgical spaces of orbitotomy and orbitotomy types and surgical techniques and the complications. The surgical spaces are subperiosteal space, extracorneal space and the intracorneal space and subtenon space. The anterior surgical approaches include superior, medial, inferior and lateral. The transcutaneous and the transconjunctival is seen in superior, medial, in inferior and lateral, which will be done by the lateral canthotomy in upper eyelid crease incision. These are the instruments done in the orbitotomy. The superior orbitotomy, the indications are lacrimal gland tumors, superior medial and the lateral tumors. This is the transcutaneous incision. This is the vertical eyelid splitting incision. Through the orbicularis oculi, we can get access to the subperiosteal space by removing the periosteum, and through the orbital septum, we can get access to the extracorneal space, and through the intermuscular septum, we can get access to the intracorneal space. During this surgery, we have to take care of LPS and superior oblique trachea and the lacrimal gland. Inferior orbitotomy. The indications are orbital floor fractures, orbital decompression, and deep intra and extracorneal spaces. This is the transcutaneous and the transconjunctival incision. Between the orbicularis oculi and the lid retractors, we can get approach to the subperiosteal space and from there to the extracorneal space, and through the intermuscular septum, we can get access to the intracorneal space. During this surgery, we have to take care of inferior oblique, inferior rectus, inferior orbital nerves and vessels. This is the video which shows the inferior orbitotomy. We are giving an incision to the transconjunctival incision like this, and we are removing the periosteum as shown in the video. And the pink one shows the fracture of the orbital wall. By showing like this, we have to retract the periosteum. After that, we have to retract the heavy orbital contents like this, and we can view the fracture wall. They can close the fracture with a mesh. Medial orbitotomy. The indications are tumor, fractures, optic nerve fenestration and decompression of the medial orbital wall. This is the transcutaneous incision, this is the transcaruncular incision, this is the transconjunctival incision. This is the picture which shows medial orbitotomy. Medial orbitotomy is the easy approach for the lacrimal apparatus. So we have to take care of the lacrimal gland, lacrimal apparatus during this procedure. So apart from that, we have to take care of medial canthon tendon, superior oblique and inferior oblique. The lateral orbitotomy indications are lacrimal gland tumors, retrobulbar tumors, and orbital wall decompression, dermoid and cavernous hemangioma. This is the upper eyelid teeth incision. This is the lateral canthotomy. So by removing the temporalis, we can get access to the subperiosteal space, then extracorneal space, then intracorneal space. Lateral orbitotomy is a good exposure, well tolerated procedure and less complications. This is the post-operative complications. The most common is diplopia and the persistent dilated pupil due to the ciliary ganglion. The most commonly performed orbitotomy was, audience? Yes. And the advantage of transconjunctival incision was, students? Yes. The lateral orbitotomy is the most commonly performed orbitotomy, and the cosmetically better is transconjunctival incision. Thank you.
Spectacular. Spectacular is ready now. Do you have team PGIMS? You can be ready next. Iconics, last team. Iconics. You are there. Okay. No, Abhi. Dystrophy demystified. Okay. Spectacular can go ahead. Yeah.
Good evening. I'm going to do a very important topic, so please pay attention. Now, are you the one who gets nervous when he sees a patient like this? Well, if so, don't worry, because we are all on the same boat.
However, we can solve the situations if we can ask ourselves three main questions. First, is it a dystrophy or a degeneration? Second, which layer of the cornea has been involved? And finally, what is the next diagnosis? Now, if your patient is someone who presents to you early in age with familial symmetric bilateral central opacities, then congratulations, you have successfully diagnosed a corneal dystrophy. Did you know that dystrophies in cornea are that common? Well, they are, and that is why the International Committee for Classification of Corneal Dystrophies takes the onus on themselves to classify dystrophies on the basis of genetic analysis, anatomic phenotype, and pathology. The classification is done layer by layer, and let us look into each other for now. The first is the epithelium. Now, the epithelial dystrophies make the cornea susceptible to various types of environmental insults, making it the pain and photophobia the major clinical features. The epithelial dystrophies can be remembered using this very, very easy mnemonic: my really messed up eyes look green on Mondays. The various dystrophies, as you know, you can see the morphology here: geographic lesions in MAC dot fingerprint dystrophy, recurrent erosion syndromes, the juvenile onset presenting Meesmann dystrophy, the leash corneal dystrophy, and the gelatinous and subepithelial mucinous dystrophy. A few words on the Bowman layer dystrophies also. The two types mainly are Rees-Buckler and Thiel-Behnke corneal dystrophy, which are all autosomal dominant in inheritance and show mutations in the TGF-beta gene. Now, what happens in Rees-Buckler dystrophy is that there is abnormal keratoepithelium, and this makes subepithelial rigid opacities which are deposited. We now come to the major chunk of dystrophies, that are the stromal dystrophies, and it's simply like Ram Teri Ganga Maili Ho Gayi, because many deposits come from here and there and get deposited here, causing glare, photophobia, stromal haze, but you can differentiate them that they are F stain negative. Now, she's your favorite actress, and you can always remember her and her mnemonic: Marilyn Monroe always gets her man in LA countryside with crystal snipers. Here is the table for different stromal dystrophies, along with what gets deposited and the stains. And now, a few words on how you should differentiate between macular and granular dystrophy. That is only on the basis of the fact that macular dystrophy will present in the first decade with indistinct margins and hazy intervening stroma. Now, the last layer of dystrophies, that are the endothelial dystrophies, which can be remembered using this mnemonic. And how to differentiate between the three, that is only on the basis of the age of presentation, because Fuchs is adult onset, and on the presence of Gate or railroad regions or ground glass opacities. Now, I have given you all handouts. At the last class, I know none of you have made any notes, so kindly use my handouts and use this algorithm to detect which dystrophy it is. And here's your food for thought. If you can do it so easily in 3 minutes, why can't AI? So these are the recent advancements. You go home and you check on them, and this is your homework. Please note it down. Thank you.
Team PGIMS, you are ready? Iconics can be ready next there. PGIMS can go ahead, yeah.
So, good evening, class. So, today's topic for the class is sebaceous cell carcinoma of the lid. So, here is the pictures of the lid tumor involving the margins of the lid. It can be squamous cell carcinoma, sebaceous cell carcinoma, or the basal cell carcinoma. From all of these, the basal cell carcinoma is the highly prevalent one, and list one is the sebaceous cell carcinoma with the prevalence rate of 1 to 5.5%. And basal cell carcinoma and squamous cell carcinoma arises from the epidermis, that is the part of skin, while the sebaceous cell carcinoma is the glandular type of tumor which arises from the meibomian gland, gland of Zeiss, glands of Mohs, glands of Caruncle, or the sebaceous glands of the eyebrow. So it is the highly malignant neoplasm which affects mainly the elderly person with a maximum predisposition of the females. It has an association with Muir-Torre syndrome, which has an autosomal dominant inheritance of sebaceous tumor involving the GI tract, endometrium, or the urological system. Coming to the pathogenesis, so first one is there is dysregulation of the beta-catenin pathway, and second one if there is E6 or E7 protein of HPV virus binds to the tumor suppressor gene of P53 or the RB gene. Coming to the clinical types, first one is the nodular. In it there is a nodule
firm, painless, unilateral mass which mimics like a callation. Second one is the spreading, in which the if tumor spreads to the lid margin, that is the epidermis, leading to thickening of the lid margin, which mimics a case of blepharoconjunctivitis. Third one is the phagocytoid spread, in which there is an intraepithelial spread of the tumor in phonocycal conjunctiva, bulbar or the palpebral conjunctiva. Coming to the histopathology, there is dysplasia and anaplasia of the cells with increase in NC ratio or the increase in mitotic figures, with a typical feature of foamy-vacuolization due to increase in lipid production in the cytoplasm of the cells. And the special stains used are the oil red stain or Sudan 4 stain. Coming to the TNM classification, any tumor less than equal to 10 mm in greatest dimension is T1, 10 to 20 mm is T2, 20 to 30 mm is T3, which are further divided into A, B and C depending on the involvement of the tarsal plate or the full thickness involvement of the eyelid. If any tumor invades the ocular, intraocular or the facial structure is T4, which is further divided into A and B. If any tumor involves the regional lymph node, then N1, tumor involving the distant metastasis, then M1. Coming to the treatment part, so gold standard treatment is the wide local excision, as shown in the picture with 4 mm clear margin. So intraoperative frozen section should be used to rule out any positive margins. And later on, further process to the lid reconstruction surgery, either Cutler beard or the reverse Cutler beard, depending on the lid involvement. So any tumor more than T2 or more than 10 mm in diameter, sentinel lymph node biopsy should be done. In case of phagocytoid tumor, map biopsy should be done. Any tumor more than T3 or involving the intraocular or the orbital structure, should be orbital excision should be done. Cryotherapy in mitomycin C should be used in case of positive margins or the recurrence. And any tumor T3 or T4 or any metastasis, chemoreduction in form of systemic chemotherapy like in 5-fluorouracil or cisplatin should be used. Thank you.
So last presentation, Iconics. Yeah, go ahead.
Good evening, everyone. Saving the best for the last, and definitely no homework since everyone has so much already. Coming to retinal photoreceptors, these are special sense cells containing photopigments that absorb photons of light. Keeping it very simple, they include rods, responsible for your scotopic vision, vision in the dark, contrast sensitivity, brightness, and motion. Then we have the cones, responsible for your photopic vision, fine resolution, spatial resolution, and color vision. A little about the distribution in the retina. As you can see in this diagram, the rods are absent at the fovea, present densely below the optic disc and in the periphery, decreasing at the extreme periphery, whereas cones are the most dense at the fovea. A little about the structure of the rods and cones. So the outer segment of the rods is rod-shaped and hence the name rods. These outer segments have membranous discs stacked one on top of the other with the visual pigment rhodopsin in rods and photopsin in cones. The photopsin in cones respond to different wavelengths of light, blue, red, and green, and therefore responsible for color vision. Connecting these outer segments to the inner segments is the connecting cilium. Then we come to the inner segment, which has two parts, the ellipsoid zone containing the mitochondria and the myoid zone that has the endoplasmic reticulum and the Golgi apparatus. Then we have the cell body containing the nucleus and the synaptic endings, in rods called the rod spherule and the cones called the cone pedicle. Its representation within the retina includes the photosensitive area forms the layer of rods and cones. The part between the inner and outer segments is the external limiting membrane. The nuclei or the cell bodies correspond to the outer nuclear layer, and the synapse between the bipolar cells and horizontal cells form the outer plexiform layer. A tabular form representing the same. A little about the physiology. So light adaptation. When you go to a movie and you come out for the intermission, you come from dark to light. What happens is the pupils will constrict, allowing light to be focused on the fovea, where the cones will be in abundance. This will cause bleaching of rhodopsin, and in simpler words, the rods will get turned off, decreasing the retinal sensitivity, low sensitivity cones turned on, increasing the visual acuity and color vision. This takes around 5 to 10 minutes. Now you want to go back to see what's happening in the movie, you go from light to dark. So what happens is the pupil will dilate, allowing the light to go to the peripheral retina where the rods are stimulated will result in accumulation of rhodopsin. Rods will get turned on, increased retinal sensitivity, and the cones are turned off, decreasing the visual acuity and color vision, taking about 20 to 30 minutes. So in summary, we have around 110 to 125 million rods versus 6.3 to 6.8 million cones. Rods are responsible for your contrast sensitivity, your brightness and motion, whereas cones for your fine and spatial resolution and color vision. The rods are absent at the fovea and increase toward the periphery, whereas the cones are most dense at the fovea. The outer segment of the rod is rod-shaped, containing rhodopsin and thus monochromatic vision. Outer segment of the cone is cone-shaped, contains photopsin, responsible for color vision. The regenerative power of rods is high, whereas that of cones is relatively low. Thank you.
Yeah. Anybody is left in the audience who have not presented in this session? Right. We'll close it, sir. Yeah.